Yeah, amphetamine was originally marketed, actually, Adderall was originally marketed in the 70s, I think, as Obitrol.
Okay.
And it got pulled not because of safety, but because of efficacy, because most people acclimate.
It was as a weight loss drug.
As a weight loss drug.
Right,
yeah.
right. So
Obesity
now it's a side effect.
Now it's a side effect.
That it will suppress your appetite, even though you won't lose weight. So.
Yes. But, one of the things that's, a tragedy, and we're setting ourselves up for all manner of problems as a nation, is the obesity epidemic in kids. I see so many kids in my practice who are obese. I'm not talking about, growing up we all had
little baby fat or whatever. Yeah.
I was a chunky kid in middle school, and then I sort of grew, as my grandmother used to tell me, you'll grow into your weight. Don't worry, that kind of happened for me. But I see people who are morbidly obese as kids. But Patty, actually, Amy and I were going to do a podcast, and Amy's sort of like, for a variety of reasons, including 2 teenage sons, she's like, I don't really want to do this.
Mm-hmm.
And so we talked about Patty and I doing it. Mm-hmm. I think like having the three of us, I love Patty. And as you saw, Patty is
She's wonderful. She's wonderful human being.
Sharp.
Yeah, I've talked to her. We good?
Yeah.
Okay, so we're good. So I figured this in the beginning, we'll talk kind of about your career, what, your intellectual background, things like that, and what neuropsychiatry is.
Yeah.
I definitely want to get to TMS.
Sure.
Because I feel like you're a wealth of knowledge on that, neurofeedback, some other things. And then I think we'll take a break about 2 hours, Taylor.
That's good.
Ish. If you need to take a bathroom break, this can be edited.
Sure.
And then the second half, we can talk, I guess, a little bit more personal things.
Sure.
Sound good?
Yeah, sounds good.
Cool. You ready? Do we need to do that? Are we doing our own thing? Okay, great. I just did it. All right. Dr. Clark, thank you so much for joining me.
I'm truly excited to be here and flattered to be asked to join you.
Thank you very much. So when you're at a cocktail party or at a networking event and someone turns to you and says, so Craig, what do you do? What's your answer for that?
Well, okay. So when I was younger, I started my career really as a child psychiatrist. I'd come to Vanderbilt in the combined program in neurology and psychiatry, but I quickly learned most of the people going down that path were going to be academics, and I didn't really want to be an academic. I wanted to be a clinician. And so early in my career, probably 80% of my patients were under the age of 25, let's say. Yeah. And so people would ask me that question. I would say I'm a professional checkers player. Because I played checkers all day with little kids and Old Maid and things like that, and they sort of look at me like and then as time went by and those kids that I started with all those years ago, some of whom I now treat their children. Okay.
Wow.
Some of the adults I treat their grandchildren. All right. Wow. You can guess my age based on that. But I now say, when asked that question, I say I'm a professional difficult conversation haver.
Oh, I love that. I
like that. Yeah.
So is this that conversation? Is this an intervention? Is that what we're here for? But before, let's back up a little bit. I mean, how did you decide on a career in medicine, and how did you decide on psychiatry?
Yeah, well, I grew up in a small town in West Virginia, and my best friend's father was a true family physician. Like, he was an old-time family doctor. I mean, he's a very interesting guy. He was a very strong patriot as a kid. He volunteered immediately out of his internship to go to Vietnam as a medic. He was a medical doctor, but he worked as a medic. There are tapes of him corresponding back home with his family where you hear mortar shells in the background and all these things. He won the Bronze Star for his service in Vietnam, and he was very much like a role model to me. I thought that's the path I wanted to go down. I thought I wanted to be a family doctor. And I read the writing on the wall at that point that the changes in medicine that were coming, I wouldn't be doing what he had done, which was soap on fingers and birth babies and do, cradle to grave medicine, that it would be more like I'd be a gatekeeper at a portal. I didn't really want that. And I always had an interest in the intersection of science and the arts. And so my undergraduate major was chemistry, biochemistry. I think you heard my story about why I don't have a double major, which if we have time, we can delve into that. But the other was psychology. And so I'm one of those rare people that actually uses what I studied in college.
Yeah.
And that sort of set the stage for me to become a doctor. I so admired Dr. Kleinsteiber is his name, and I so admired him and looked up to him and sort of set me down that path. And then the fork in the road came with first neuropsychiatry and then ultimately child psychiatry, which are one and the same
For you. Yeah.
Yeah, for me,
Yeah.
the way I
Yeah.
practice.
So in the traditional path, I guess, in medicine, you'll go to medical school and you'll just study the same thing every doctor does, right?
That's right.
I mean, so you get 4 years of
4 years
medical
of that, yes,
and
that's
then
right.
you'll have a residency, and yours ended up being with
Yes.
neuropsychiatry.
Yeah. So mine was, I had an internship at Vanderbilt, and mine was a little bit different than most psych internships because I didn't do anything other than medicine and neurology because I had set down that path. But once I figured out that the dual path wasn't what I really wanted to do, then I had 3 years of psych, adult psych. A running joke with me is that, to be boarded in child, you have to be boarded in adult first. And I always say it should go the other way because then you would understand the adults.
Developmentally, right? Yeah, that would make a lot more
Right,
sense. Yeah,
right.
yeah.
Create the context, right? So did the adult, and then I really fell in love with child. When I did my child rotation, honestly, I went into that thinking, I'm going to kind of grin and bear this. I don't really want to do it. And then once I was in it, I just have always been interested in people and human development, and here it was sort of unfolding in front of me. And that's the first time that thought occurred to me that if I'm going to be an adult psychiatrist, I will be so much better at it if I understand that this didn't just materialize out of thin air,
Right.
that it came from somewhere. There's a
Yeah,
backstory.
you have context, like the whole picture.
That's right.
I think there's so much I could say about that. I mean, where the thing you mentioned first is that you were seeing that medicine was changing.
Yes.
And it's interesting that you would describe family medicine, internal medicine as gatekeeping now,
Yes.
which it does seem like you can't see a specialist unless
That's right.
you get a referral, and it's almost like what those people are there for,
That's right.
which seems to be like a waste of resources, honestly.
Well, and it's a waste of a opportunity where someone, and I pride myself on this in our own practice, and what we do is like, medicine is about first and foremost relationships with people and developing that relationship over time. And again, your understanding of someone matures, and equally importantly, in my humble opinion, their understanding of you matures. Okay,
Trust.
because
Yeah.
it is an interaction.
Yeah,
Right.
yeah.
It's not speak to the oracle and they tell you what to do.
Right.
Okay. So
This just in, like, what was it, Johnny Carson would get the thing and he'd be like, oh, it's borderline personality. What would you know? Yeah.
Exactly.
Right.
Exactly.
Yeah.
Like you have to arrive at these things together. We can talk more about that later too, because it's a funny question about the best treatment plans.
Yeah.
It stems from that, but that it's an interaction, and that trust is the foundation of that, and that's built over time. And so one of the things I hear from patients every day of my life, and I've lived it a little bit in my own life with occasions when I've needed access to the healthcare system, or recently when my wife needed access to the healthcare system, that you get these discrete sort of packets of interaction, and it's like literally 10 to 20 minutes, and then you're just kind of on your merry way. And it's like, well, wait, what? And I mean, I am a doctor, and I would walk out going, what just happened there?
Yeah.
Right?
Yeah.
So there's no continuity, and I think that's what the old school approach, the primary care doctor who knew you, followed you, treated you. And yes, if there was something really outside of their expertise, they would have a fiduciary responsibility, and they would be, negligent if they didn't send you for consultation. But it was consultation. It wasn't farming you out to 36 different doctors.
Right. Who don't see the whole picture.
That's right.
Necessarily. I mean, and
right.
because we have HIPAA, is one of these weird things in this country. We have HIPAA. We have these great protections, but they balkanize information for the people that actually need it. And there. I mean, will be the first to say that, like, being discriminated for a medical diagnosis is a real problem.
Oh, sure.
But we do now, because of the opioid crisis. At least what other people what their prescriptions are. What prescriptions are being filled.
Right.
Right. And so there's at least that from a safety
Right.
perspective. But you don't know the rationale behind that.
That's right.
I mean, so I can see what you mean about. I've had this issue with myself. Navigating the healthcare system is so complicated because I really just wish I could have one person to manage all of my things. And do you think the pediatrics still works that way? That was my experience growing up in the 80s and 90s, that I had one pediatrician. He had a partner who knew, who I was, but that man was at my high school graduation, and like,
Yes.
yeah. Does it still work that way, do you think?
I think it largely does. It's interesting you bring that up. The same pediatrician, and I'll give him proper kudos here. And a man by the, I started to say a young man. He's my age, so
Okay.
no longer qualifies as young. Sorry, Paul. But a guy by the name of Paul Heil, who I knew from training, our contemporaries, colleagues. I have a son who's 33, and then two younger sons who are just turned 16 and soon to be 15. Dr. Howell has followed them the entirety of their lives. In the case, obviously, my older son, aged out of the pediatric practice. But we recently just got his retirement announcement, and I tell you, I mean, it was like, oh, ouch,
Yeah.
and I'm sure the person who's taken over will be great, and we'll get to know him and all that good stuff. Paul wouldn't hand off to someone that wasn't great, but it's a vestige of the old system. It really is. Yeah, I think that's probably the one place, and maybe arguably OBGYNs who pick up ladies when they begin to menstruate and need that kind of care and may follow them through pre, peri, and postmenopausal years and treat them.
They're both very personal
Yes.
decisions. Generally going to be made by mothers, I
Right.
think, for their children's care, and
Right.
that's a really personal decision. And
Yep.
hell hath no fury. I mean, I just feel like the mothers in our society wouldn't accept anything less. They wouldn't accept being treated like a number.
No, absolutely.
Yeah,
And one of the truths, I mean, as a child psychiatrist, I can tell you this is with absolute certainty: the instinct to protect the young is more powerful in human beings than the instinct for self-preservation.
Yeah.
And that's true in both fathers and mothers, but mothers in particular. Like, don't mess with that kid. That's a big mistake.
Right. Yeah. So there's a few things I've always wanted to ask a physician, mainly about what is medical school like? What do people learn there? What's the style of learning? You were a faculty member at Vanderbilt, were you not?
Yes, I was on the clinical faculty for years. I actually supervised people who were in their 5th year of fellowship, and that meant that they were somewhere between 0 and 12 months from hanging up the independent shingle.
Okay.
So I was catching them at the absolute tail end
Yeah.
of the process. But in the case of child psychiatry, that comes 5 years after med school.
Okay.
So there's a long...
That's it. Yeah. I think there's a lot of just confusion around. There's a series of tests that you take. You're out of medical school. You're still taking tests.
Right.
Can you just kind of walk us through the developmental trajectory of a doctor, of
Yeah.
a psychiatrist?
Sure. Well, so med school itself is typically 4 years. And there are 3 different tests that you take. Well, 2 while you're in med school and 1 immediately after being in med school. And the curriculum, the first 2 years of curriculum, historically was in the classroom. I like to say I still have splinters in my behind from sitting, 8 hours a day in the classroom for 2 solid years. And it's very much a didactic thing, at least in those days it was. And so, it's biochemistry, it's histology, it's gross anatomy. You dissect the cadaver under the watchful eye of your supervisor or whatever. You study physiology. There's psych. Psych is introduced in your first year.
Okay.
And so for 2 years, that's kind of the curriculum. And then you're released into the clinical realm as a third-year med student, and you start to actually see patients in the premises. You've sort of developed this basic understanding of pathology in various forms, what underlies pathology in the human body. And
What do you mean by pathology?
anything that would be abnormal, outside of the typical thing. So if someone has difficulty with digestion, they have a form of gastrointestinal pathology, or so goes the theory.
This is disease, essentially.
Disease, right.
Okay. Yeah.
And so you're going to encounter real living human beings that have those conditions or diseases, and you're going to start to interact with them like you and I are interacting right now, and we'll try to, engage you, learn something from you, put that through the filter of my experience, and fundamental at that point, just basic fundamental learning or knowledge. But eventually it'll be through the filter of your experience and say, okay, so you have discomfort after you eat, it's sort of a burning sensation. You feel it kind of come up into your chest. You went to the ER once because you thought you were having a heart attack, but you're a super healthy 30-something. Sounds like gastroesophageal reflux disease. And your attending will either say, brilliant, or what are you thinking? Right. And you'll sort of get shaped down, or, well, what else could it be? Maybe it's GERDs, but it could be something else. And, are you going to send him out with getting an EKG because he did go to the ER and he did say he had chest pain? How do you make that decision? That kind of stuff. That's in the 3rd and 4th years.
Right.
Now, since I left med school when dinosaurs roamed the earth, they've started doing more and more clinical things earlier on, which I think is a good move. I think that the sooner you would get people actually learning the skills of interaction, the better. And I think that, again, from patients that I work with, it's been a challenge for me to curate the right doctors to refer people to as neurologists or gastroenterologists or whatever, because so often the hard science part of it does not nicely meld with the psychosocial science part of medicine, right? Medicine is really an art.
Yeah.
And so a lot of people who would excel academically in ways that would gain them admission to med school, they're not temperamentally suited to be clinical doctors.
Okay.
You can see how that would be.
Yeah. Yeah. Well, I think you said something that I'm still noodling over at the beginning of this conversation, which is that you've always been interested in the intersection of science and art. And then as an explication of that, you told me you studied biochemistry and psychology,
Right.
which is a fascinating parallel that you would draw between psychology and art.
Yeah.
And I made a post. I'm starting learning social media. I'm on social media, Threads, this thing, because I have some just quotes and things that I say. And Threads apparently seems to be the thing that I do if I don't want to do Twitter. And I wrote about it. It came to me a while ago that if art is a form of therapy, then therapy is also very much an art form. And it's almost like an alchemy. One of the problems is with. I know that recently MDMA has gone through its third round of trials,
Right.
and they were denied approval. And I think that from my best understanding of this, I'd actually love to talk to people who are closer to it, or maybe get your opinion. But the FDA doesn't know how therapy works.
Mm-hmm.
That I think is the real problem. You can't reduce it to a single variable. And
Right.
so a lot of the feedback they're giving was, well, this depends on individuals,
Yes.
the therapeutic alliance between these people, and we can't mass produce that. And so therefore this
Yes.
drug doesn't work. and
Sure.
Right. And
Well,
and,
it's an interesting. There's a corollary here with the placebo effect too.
Right.
And one of the challenges I tell parents who are anxious about their child taking a psychotropic medicine, I'll tell them, I say, well, if this medicine's separated from placebo in a trial with kids, then you can know with great certainty that it probably is an effective medicine because the placebo effect is so powerful in younger people. And what's the placebo effect? Like that's
Yeah.
another fun topic.
let's talk about it. I have a feeling that most people in the audience will at least think they know what the placebo effect is.
Well, there are a lot of ideas about what it is.
Yeah.
But, one idea that just appeals to me, and I think it just on an intuitive basis, just as a human being myself and thinking about all the things that I've seen in front of me, is how important historically in our development as a species being part of the group was and staying with the group and receiving the protection and comfort of the group. And so if without that, we would literally not survive. Right?
Yeah.
We're social animals. We need it psychologically, emotionally, but we also needed it historically for very practical reasons, right? Mm-hmm. So if one was left behind and ignored when injured, this was bad. This was very bad news, okay? I think most things in life that you need to know are summarized in Forrest Gump. So I'll throw this out.
Excellent. Yes.
Right?
Go ahead.
Okay. So you may remember when Jenny tells him, Jenny says, Forrest, if you're ever in the battle, don't play hero, just run.
Yeah.
Just keep running. And so Forrest gets in his first firefight and he just takes off running and running. He says, well, I ran and ran until I was alone. And that was a bad thing.
Yeah.
Okay. And so then, of course, he goes back and does the
Yeah.
heroic acts of saving his fallen brothers or whatever. But the idea that when someone approaches you and says, I'm going to do something that's going to be helpful to you, I see you're hurting, I see you're suffering, I see there's some malady that's come over you, and that person approaches you and says, let me take you under wing, let me give you this vitamin, let me introduce you to this therapy, let me teach you that exercise helps, whatever they do, it doesn't matter, then you have received something interpersonally. And again, we can get into the super deep rabbit hole conversations of the energy transfer. I know you had the neuro shaman on. We're going to have the neuro shaman with us.
Shout out to Laura Martinez.
Yeah,
No,
love
the
that.
energy transfer. Yeah.
Yeah, I love that episode. And so, there's a way in which you could formulate or think about human beings as biological energy processing units, right? So we process energy, and you and I right now are having an exchange of energy, right?
Yeah.
And we can't see that. That isn't observable. It certainly isn't measurable with currently available tools.
Right.
But anyone knows that it's true. Anyone that's ever had a great friend or a trusted doctor or a spouse that they really love and value their time knows it's true, right?
Yeah. Yeah. I think actually we are breaking a science of observation with that. It's functional near infrared spectroscopy. Have you heard of this? Yeah.
I don't know much about it. Tell me more because I'd love to learn too.
It's imagine if we both had EEGs on and we were talking to each other, and there was a way to measure the coherence between the waves.
Oh,
So
yes.
at some point, I'm supposed to ask you what EEG is.
That is possible.
But yes, right.
Yes.
Well, so imagine that, but with spectroscopy, where you can actually, essentially read carbohydrate metabolism in the brain. And we're learning a lot more about what mirror neurons do, because I mean, there's a physical mirroring that they involve. I mean, you can kind of monkey see, monkey do, and that's what those neurons are for.
Yes.
But I mean, it's so new, and the trials are very, very small. Right now, I think we're at a proof of concept for the technology to show that there's a there. And I think a lot of the research is being done in Colombia, if I recall correctly. I need to go back and see. The World Science Foundation had a really cool talk on it. But there's a saying that this neuroscientist used, this term, and I love. She calls it the social synapse, which is the space between us right now.
Absolutely.
But it's, synapse is the space between. But there's information flowing, literally. I mean, we use words and sound and these vibrations, and we create meaning.
Yes.
But so it doesn't have to be a neurotransmitter, but there's neurotransmitters working here and over there, and there is something being exchanged across distance, which is
Absolutely.
spooky almost.
I completely buy that idea.
Yeah.
I think I've seen it. I mean,
really?
Yeah. Well, one of the to me, like one of the least scientific things that can happen is when there's something that's observed that isn't consistent with or explainable by known means, and people go, "Oh, right, neuroshaman,"
Right.
It's like, and there's this dismissive quality to it. And that's the antithesis of science. Science goes, So another way of saying it is science happens at the edge of our understanding, right? Like I don't understand this. I observe it. Other people observe it. Other people have experienced it, but we don't have a ready explanation for it. So does that mean it doesn't exist, or does that mean that we just don't have a means to measure or quantify? And science loves to measure and quantify, which again, I'm not saying that's bad.
Right.
I'm just saying, like, if there's anything history has taught us, right, is that there are things we don't know about and that we'll eventually know, and it'll seem like common sense, common knowledge, but at the time, so
if you look at the history of any field of science, it's mainly characterized by a bunch of scientists being later proven wrong.
Right.
I mean, essentially, that's what it is. Like that's kind of. And there, I talked with. I don't know if you heard my episode with Jonathan Rosenthal, who's a neurologist at
Yes.
Neuroscience of Yoga conference
Yes.
founder.
Yes.
We talked a little about just what is science and,
Right.
and this component of falsifiability. And that
Yes.
he said he had a professor that would say, like, your job as a scientist is to build a model to explain the world and then try to break it, try to destroy it.
Exactly.
And you're trying to prove yourself wrong.
Yes.
How does that apply to? How does that relate to a clinical practice of medicine? I mean, are you trying to prove yourself wrong as a clinician, or are you hoping that the information you're using was by people who try to prove themselves wrong?
I think it's probably both, if you sort of formulate it that way. I think that you have to be, I think good clinical practice calls for extreme levels of humility. Okay. And, as you know, I love quoting my grandmother. One of my grandmother's favorites was, the smartest people know what they don't know. And another quote from my grandmother, be the eternal sophomore. So sophomore, the knowledgeable fool in Greek, right?
Yeah.
So you can know things, and not being immodest. I mean, I think I know quite a bit about human development and psychiatry, psychology, neuromodulation, whatever. I've learned a lot, but at the same time, under no circumstances would I labor under the misconception that I know everything I'm going to need to know. And I also think a huge part of it in clinical medicine is gaining the trust, building the relationship where people will then share with you the critical information that you need. And there's this and talk about false assumptions. I mean, one of the huge false assumptions in clinical medicine, and especially in psychiatry, and I used to see this all the time when I'd supervise fellows, is that they'll meet with someone and have the modern model is very brief intervention. Have a brief conversation with that person, and they just assume that now they've sort of filled out the form that the insurance wants to see. And so I've got all the information I would ever need to know in order to effectively treat this person. It's like, well, chances are good. I don't care how skilled you are. I don't care how interpersonally adept and warm you are. Chances are good that you're not going to know the whole story for a long time. The whole story is complicated, it's nuanced, and guess what? Bad news, it changes in real time.
Right.
So you have to constantly be collecting, and I think in that sense also forming and testing hypotheses, but being willing and even welcoming of when the hypothesis doesn't hold.
Right.
Okay, here's again, this is almost better than what it does, right?
Yeah.
It's a new opening.
Exactly. Well, I
Yeah.
mean, there's this saying in among scientists I've heard that like it's a sick burn to tell someone they're not even wrong. You know, because it's like if this is an unfalsifiable thing, like it would be better if you were wrong because you might learn something. You know, like
Exactly.
to be not even wrong is just to be stuck in like an epistemic cul-de-sac and you just never get out. Like,
No, that's exactly right.
Yeah,
It's a blind loop.
It's
Yeah.
it frustrates me because that's I think in a lot of cases that's how psychiatric diagnoses work. Because it's just
Yes.
if there even is a physiological component to them, we don't know what that would be in a lot of cases, and we don't have any diagnostics for that, and so that can be very frustrating, especially because of the way medicine's balkanized now.
Yeah.
You're speaking about, I think, your philosophy of being a physician, being a clinician. I think it relates to one of the things about you that is quite unusual, which is that part of your practice involves what we would call therapy now, sitting, or I would call talking to your patients for, a protracted period of time, getting to
Imagine
know
that.
them over time, right? Which is, it's strange to say that a psychiatrist that does therapy is a really remarkable thing, but it is. It's almost like I think we're nearing a place now in the culture where that doesn't even seem remarkable, probably to a younger generation, because we don't really have the cultural representations of these Freudians or whatever of the doctor with their couch.
It's an anachronism now.
Yeah. So what was your training like, as becoming a psychiatrist? And
Right.
was that part of the training then? And what was that like for you?
It was, which again, it's really interesting because I think one of the things as you get older is you lose things. Like, you lose your hair, or you lose muscle mass, or you friends. I've had friends who pass away. Those sorts of things. You lose a lot of things. And one of the things that Amy and I talk about, my wife Amy and I talk about, is the loss of this, like, sort of idea or model that we were given and that we hold dear of how this should be approached. Mm-hmm. And the idea that, like, for example, that a medicine or even that psychiatric nosology is precise enough to inform on an individual basis all the details of a plan that you would need.
Can you clarify what nosology means?
Yeah, naming. Like how do you categorize
diagnosis.
things? Categorize diagnosis.
Okay.
And again, it's not. There's a place for it. Mm-hmm. It can definitely be helpful in the broadest sense. But one of the most important things is understanding the limitations. Like any tool that you use, it doesn't matter what that tool is. You have to understand its limitations to implement it to the best possible use. And I think like there is this overinvestment in giving it a name. Mm-hmm. Historically, I've said to patients, we can call it, what do you want to call it? We can call it Charlie Brown. We can call it, I don't care. Call it whatever you want to call it. Here are the things that are obstacles to you growing and healing and being the best version of you. What are the tools that we have available to kind of try to intervene on your behalf in that way? And then how are we going to implement those tools? And a huge part of that is, which tools are you comfortable using?
Right.
In other words, it's not speak to the oracle and walk away with, whatever, some prescriptions and a follow-up in 6 months. It's like, it's a dynamic interchange between human beings, and people have different feelings about that.
Yeah.
But to your original question about how I was trained.
Training, yeah.
So I call it, I referenced Forrest Gump earlier, I call it my Forrest Gump life. When I came to, because I do.
That's cool. You had a cool life, yeah.
I've had a cool life. Yeah. And I showed up at Vanderbilt at a very unique time. The outgoing chairman had been the president of the American Psychoanalytic Association. Okay. And Dr. Hollander, I had him briefly as a supervisor, Mark Hollander. And at that time, the incoming chairman, Mike Ebert, was literally like interested in fractionating monkey brains. Okay. So you could not have
interesting. That's an interesting changing of the guard. Yeah.
Very interesting changing of the guard. And Vanderbilt was a psychoanalytic institute, I believe, in those days. So you could go there and train to be an analyst. You could receive your analysis there. And so, the traditional Freudian psychotherapy was, it was a stronghold, right?
Yeah.
And so I had Dr. Ebert was my advisor. Dr. Hollander was one of my supervisors as a young psychiatrist. Mm-hmm. I love telling the story about Dr. Hollander. I went to Dr. Hollander's for my first meeting of supervision, and he had a photo hanging on the wall. and he was standing in a bar with his arm around Kurt Vonnegut. Okay.
Okay.
And
Cool.
and I recognized Kurt Vonnegut, of course, in the picture, and I was like, oh, that's. And so he came in and he greeted me or whatever, and I said, Dr. Hollander, who's that in the photograph there? I knew who it was. And he looks at me and he kind of steps back and he goes, well, it's me. Which is
Excellent. Right. So he's a medical school professor, is what you're saying. Yeah.
excellent response.
Yeah.
Yeah, never mind the Vonnegut guy. Who cares about
So,
him?
what are you talking about? Yeah.
But so when I went through training, there was a very significant emphasis on psychotherapy. A lot of that was analytically tinged, but we were taught that, the best care, which I still believe, the best care really integrated because they're different things and they complement one another. They're not in competition with one another. They complement one another. And so I was taught that, psychotherapy should be a part of every patient's treatment plan, and that we were the people who had the best training to do the psychotherapy, the psychiatrist. Now, nothing against psychologists. I have to say I like it so much I married one, right?
Right.
But and I deeply believe that psychologists can be tremendously helpful. We have them on our team in our practice now, But we were taught that, like, look, you have the highest level of training. You're going to have that broadest understanding because you have the medical, biological, developmental, as well as psychological, emotional, social understanding.
Right.
And so your job is to kind of lead that team. And maybe you don't see every individual patient for psychotherapy, but you understand what psychotherapy is, what its role is, how it complements other medical treatments. That's just part of what you do. Right. And at the same time, David Baer was my mentor, who was a neuropsychiatrist. David Baer, very interesting guy. One of the things he did that was kind of cool was when Hinckley attempted to assassinate Reagan, he did the neuropsychiatric evaluation on Hinckley. He's kind of well known for that. But he's definitely, the brain is the organ of the mind. He was very interested in the intersection of epilepsy and clinical psychiatry. And so Dr. Baer was very much a neuropsychiatrist, and that's how I came to be under his supervision. And he mentored me in the early part of my career. So this very interesting, again, the monkey brain, the neurologist, and then the
analyst. Yeah. I mean, it seems like it's kind of almost like the collision of like counterculture with Reaganomics, happening at that, basically when those two things came together.
Indeed it was.
There was a little bit of both involved, went from like very woo-woo to very materialistic. So in your training, did you have to submit to psychotherapy? I hate to use the word submit, but like, were you analyzed?
Yes.
And like, did you do analysis?
I did not do analysis. You weren't required to do that. I had colleagues in the training program who did participate in an analysis. And that was available to you. I think it wasn't free, but it was some sort of discounted rate or something. If you wanted to go down that path, you could. Yeah. But I one of the most positive experiences in my life was we were required to attend this. It was weekly, 90-minute group, and it was populated exclusively by psychiatrists in training and psychologists in training. It was led by a psychiatrist and his psychologist wife.
Okay.
About this experience, I like to say, nowhere to run, nowhere to hide.
Yeah, no doubt.
Okay.
Yeah.
And I learned, my first few visits there, I was like, why am I here? I'm the happiest guy I know. This is ridiculous. I don't need to do this. And then I'll never forget, I could tell you the room, tell you who was sitting there, the coffee cup I had, what I was wearing. It's burned into my memories. I had this autonomic discharge, and I wasn't even talking. Someone else was talking about their development. And all of a sudden, I was like, oh, my God, I have issues. Yeah. Right.
How old were you when you had this realization?
Let's see. That would
mid-20s, like
20s. Yeah, 27.
Yeah,
something like that.
That's the time. I think that's a time developmentally where people just at that time start to realize, oh, wait a minute.
I
don't have it all figured out, and maybe some things in the past were like not normal, and
exactly.
maybe need some further investigation.
That's exactly right, Andrew.
It really is. Yeah. They're saying someone
So
told me the other day that they were glad they escaped the 27 club because there's a number of artists who have died at the age of 27. It's
sure.
A number. Jimi Hendrix, I think, was 27. Janis Joplin, Chris Farley. There's a bunch of people that were right at that age. Drug overdose. They had succeeded enough to be wealthy enough to be able to afford a real drug habit, and that's generally how they died. Amy Winehouse.
Oh, Amy Winehouse.
My generation.
Right. Yeah. They told me to go to rehab. I said, no.
Yeah.
Right.
Yeah.
No. So I think it's very interesting too about the 27 club because in typical, assuming everything's going swimmingly, right on plan, especially for we men, our brains aren't going to be done growing until mid-20s. And I think that growth, particularly the frontal cortical networks, allows a kind of self-awareness that opens the door for those kind of, positive revelations, self-understanding,
Yeah.
but also probably causes you to go, uh-oh,
Yeah.
this
Right.
is real.
Yeah.
Time to adult,
Right.
all
Right.
those kind
Yeah.
of things.
Yeah. There's, and that,
Yeah.
so, and
Yeah.
this is relatively recent knowledge that we have that
Yeah.
the male brain is, I think we're continuing to push that age back
Yes.
of maturity,
Yes.
right?
Yes.
How do we know about that?
Yeah, we know through neuroimaging studies that have been done that suggest that the full maturation of the nervous system and the last thing in human beings to be done growing typically is the right prefrontal cortical area.
Okay.
It's the seat of inhibition. It's where a lot of action in ADD, the ADD world, a lot of people talk about. There's, underactivity. We see that. When that's demonstrable in various types of imaging. We see it on quantitative EEGs we do in our practice. It's just sort of an underactive right prefrontal
Yeah.
cortical
So you're
area.
looking at, and just, I guess at a population level, you can look at men and versus women at a certain age.
That's
and So
right.
it's activity. Is it also seen in like cortical volume, or is it really just activity?
I think it's both. I think it's, that I'm not absolutely 100% sure of, but I think it's both.
Yeah.
And I can tell you as a clinician that it's like people past that age and things can really start to get better. I was sitting this morning with the parents of a 16-year-old, and part of it, at my age and stage of this game is like, the dad is saying, oh, he's disrespectful and he's challenging me on everything. And I was like, welcome to the club, buddy.
Yeah.
I have 3 sons, welcome to the club. But and we were talking about like, these years for people with neurodivergence, neurodevelopmental differences or atypicalities are so important because if you can just kind of shepherd them to that 26, 27, 28. In the world of ADD, we think a lot of people, again, their brain is just more slow to mature. That's why it's been referred to as the classic neurodevelopmental disorder.
Yeah. Okay.
And then their maturation may come along late 20s, even early 30s. And I see that in my clinical work. Like all of a sudden, they're different.
Yeah.
I say all of a sudden. It happened gradually, but it feels.
Are you
as if-
seeing it in terms of like conscientiousness or like outward signs of
Absolutely.
just being able to adult?
Think
Yeah.
ahead.
Yeah. Think ahead.
A
Yeah.
huge thing is think ahead.
Yeah.
If
Or reverse planning is also really hard for me. Like, it's like I need to be there by noon. What do I have to do?
What I have to
when
do
do
at
I need
8?
to start? Yeah. When do I need to eat? Yeah. Yeah. I mean, I'm 39 and I'm still working on it, but like, I get it. But there was a noticeable shift for me too.
Yeah.
Around 30 where it's like,
Yeah.
oh wait, I can somewhat manage an adult life now. Yeah. So we were asking about your training.
Yes.
You also, I think you told me once that you perform a role involving current child psychiatry. I think the boards.
Many years ago, this has been many years ago, I went one time and helped administer the boards. Yeah.
But you're talking to people coming out
Yeah.
of their residencies now.
Yes, that's right.
How are things different now versus when you did your training?
Yes, I stopped supervising residents a few years back. There was a change in the guard at Vanderbilt, and there were some internal changes in terms of how that works. So I haven't been doing that in the last number of years. But I think that in terms of like our practice, we've been at various points interested in possibly recruiting someone. And again, maybe this is my grandiosity, but I sort of thought like, hey, this is a pretty nice place to work, and it's a sort of a unique situation. You do a lot of things that make doctors miserable that you won't have to deal with if you're here. And what I learned is that, and this is a loss and this is a sadness, is that what happened is that we were interviewing these people and these child docs. And they were like, well, but I can get this job remotely supervising nurse practitioners, and they're going to pay me $400,000, $500,000 a year, and I won't ever really have to see anyone. Maybe push comes to shove a few patients a week, but I'm really going to be in a remote supervisory role. And I've got little kids, and I can stay home and help my wife, and just basically have a couple of Zoom calls a day and make an enormous amount of money.
Right.
And so I think that especially for the people who are at that penultimate level of training, the child doctors, go a few years past what even the adult doctors do. So they're highly qualified, and the way the corporate medicine machine sees them is they're going to play this supervisory role. They're not going to actually conduct the treatment themselves. That's going to be farmed out to nurse practitioners, licensed professional counselor, whomever. And they're, in theory, they're providing the supervision. But if you don't ever really see the patient, or you only see them very infrequently.
You're basically renting their license out, essentially, for the nurse practitioners to be able to.
You said
I said that.
I didn't.
Yeah, I'll stand by that. I mean,
Yeah.
there's a lot of that going on. I mean, a lot of like TRT clinics work that way too.
Oh yeah,
There's going to be a licensed physician, but none of the patients there will ever see that person.
that's right.
But there's the law requires there to be a license.
That's right.
Yeah, but I could see how if I'm an insurance company, I would, or I'm deciding, I'm the payer. I'd rather have 15 nurse practitioners, one psychiatrist, because they're all going to dispense mostly generic drugs, and I'm not going to have to bill a psychiatrist out for 18 people's worth of caseload.
Right.
That's just saving a lot of money, and the outcomes are so hard to measure if they're not materially any better because of that model or worse. That's one of the challenges is like, how do you prove that you're compromising care? That's my concern. Like as a patient who's trying to advocate for this, it's hard to prove it when it's being done right. Like that's a real challenge.
No, that's exactly right.
Yeah.
Well, and I think again, like I said earlier, like knowing the limitations of any tool, the same as like knowing the limitations. Like what one theory would be. Okay, so there, one of my favorite topics, which I'm trying not to get salty on your podcast, but like the
Let's do it. Let's do it. That's what we're here for.
Yeah, one of my favorite topics is the concept of evidence base. And
Dr. Patty and I talked about this last week.
Did you?
Yes, it came up. I could smell the ambivalence in the air. Yeah. So tell me about evidence base. What does that mean?
Well,
what does it really mean, and what do people think it means?
Yeah, I mean, I'll tell you a comical thing, and then I'll be serious for a minute. Okay. So you know how I am.
Yeah, sure.
I think people remember the comical things better. So patients will approach me and they'll say, Dr. Clark, this is awkward because I really like you and I know you're trying to help me, but you haven't really mentioned behavioral activation. And I was talking to ChatGPT, and ChatGPT said, what I really need is behavioral activation. And you just haven't mentioned that. And so I just need to know, before we press on any further, are you certified in behavioral activation? Now, I'm not picking on behavioral activation because, frankly, I think it's a great concept.
Yeah.
But one way to think about this is every 25 years or so, someone takes an old concept, renames it, writes a book about it. From this, we create a whole series of seminars. You can go to Opryland on the weekend, get a certificate, hang it on your wall. You can put a little, like behavioral activation thing on your website, your Instagram profile. I'm certified in this. Yeah. And my response to that at the time, and again, this is someone I know well. I wouldn't say this to a new patient necessarily, but I said to this particular person, I said, if only I'd thought to tell people to do things that make them feel better. I don't know what. All these years, what was I thinking?
Such a profound idea.
Yes, it's like such a deeply profound idea. And so things like this come along and they kind of catch on. Another youngster a few years ago told me, ever since Dr. Siegel invented mindfulness, the famous
Dan Siegel? Yeah, okay. Yeah, all right, got it.
And I was like, well, please don't tell the ancient Chinese
don't tell the
cultures.
yogis. That, oh my gosh. Or
they think someone else invented it.
It's funny you said like every 25 years they'll reinvent the thing, and I was thinking, man, they should develop psychotropics. They could get it down to every 7 years. You just repackage the same thing.
Exactly.
Call it new. Yeah.
Don't think they aren't doing that.
Yeah, of course they are. Yeah, of course they are. Yeah,
That's right.
I think Zoloft is basically kind of like that with Prozac, essentially.
Well, do you know how many different names there are for methylphenidate?
I've taken a good bit of them. I've had Ritalin, Concerta, Mideas. No, Mideas is amphetamine. I've had Meditate CD.
Meditate CD, Cotempla, Ritalin SR.
Those are new.
Daytrana. Yeah. There's a long list.
Yeah.
They're basically like 30 some odd. I think at last count it was more than 3 dozen.
Wow. Brand names.
Stimulants. Right. And they're all it's delivery mechanism, and arguably the delivery mechanism can matter on an individual basis. I'm not saying that isn't true. It is true. But they're all methylphenidate or amphetamine. And so it really is. I mean, it's a strange place in America where, science and clinical medicine intersect with commerce.
Right.
Yeah.
When I've talked to a lot of people, and there's I think a movement, I would call it, called critical psychiatry, which is, and I think I think that name should not be as redundant as it is, but it's basically just taking a critical or skeptical eye to the evidentiary basis for what we see as modern psychiatric medicine. It would be critical of things like that. The intersection of, in the United States, 40% of the pharmaceutical industry's profits come from psychiatric drugs. It's an amazing product because it will never cure anybody. Usually it leads to them needing more of the drugs to manage the symptoms.
Right.
And you take it every day for the rest of your life. And if you try to stop, you get sicker than hell. And we call that a relapse, and it's your fault. So it's a great business model. And people in other kind of talked to some people in the Anglosphere. I've talked to people in the UK and in Australia.
Right.
I'm hoping to have actually a couple of them on soon eventually. But yeah, they're just kind of looking at the research basis and just saying, like there's kind of a creep between you'll have something very narrow with the FDA approval, then you get all this off-label applications. And we're basically trying to wholesale out antipsychotics as being like, oh, you got a little back pain, we'll just give you some antipsychotics for it or whatever. Let's just sell more of it while we got the patent. And
expanding the indication.
Right. Well, I would say growing the market is really what they're doing. And people, and they think that we have drug commercials is just
you had to have the air quotes.
Yes, we got it. Yes, expanding the market.
Yeah.
Well, that's another thing we could talk about too. Is just like the diagnostic creep, that's happened over time. I mean, when you became a psychiatrist, which DSM were we on? Was it 3 or 4?
3.
DSM so you've been through 3 DSMs now.
Then I almost caught the tail end of 2.
Okay.
I think 2 when I was in med school, maybe 3 there. Something like
that was a big change between 2 and 3. 3 was 1980?
1980.
Yeah, that's a big change. I've read a lot about that time is where we went from almost entirely analysis, I think, in the second one, right? And then the third one was when we kind of started adopting the medical model.
Yes.
Yeah.
But I want to circle back to the evidence base a little bit.
Yeah, please.
Because because I left it hanging with what I thought was the humorous story.
Yeah.
But the evidence base, like everything. So these studies, I mean, when I taught, to this day, I try to teach my team, younger people in the team who I think are really sharp and really do care. I mean, we've curated this team of people who are amazing. And a huge part of being amazing in what we do is caring.
Yeah.
And you have to care.
Yeah.
And you also have to be able to think and to think critically and to not just take everything hook, line, and sinker that's given you, right? And so like the evidence-based thing, most of these studies are done short-term. Mm-hmm. They use, by necessity, and again, I think Dr. Patty would probably say something similar. By necessity, they use things like rating scales. Mm-hmm. Right? How are you going to quantify the change? Yeah. You have to have some sort of a rating scale. Yeah. Sometimes they make up their own rating scale.
That means you ask someone on a scale of 1 to 10, how do you feel?
Yeah.
Right. And or a scale of 1 to 7, and then so there's some obvious issues there with subjectivity, changing even within one person over time. But
and their own ability to stand back and observe themselves.
But you've got to have some sort of data, right? Some sort of measurement. So that's the best we can do right now. Yeah.
Right, and the placebo effect,
right, is real.
And, I mean, there's just so many different things. But say depression study uses the PHQ-9, 9 questions about how you feel, all of which are felt to be in some way germane to mood and progress towards relief from melancholic depression. And so you do some type of an intervention and you periodically administer this, and then creates a beautiful PowerPoint graph with the line going down or not, and the placebo or control group that didn't receive the treatment, did it separate? Some of the limitations of the math that's applied there, like everyone, the mighty p of less than 0.05, which is less than a 5 in 100 chance it happened by
randomness,
random chance alone, which sounds like that's pretty good. Yeah. But then if you really look at individual predictability, it's like 51-49.
Yeah. So it's like retroactively you can go, well, there's less than a 5% chance this was random. But with that, when you look at that test's ability to predict future results, which is kind of the point of science, is to be able to predict what's going to happen reliably. And that's what I would say, like the diagnostic utility, the utility of like these diagnoses is very low. Or of an intervention is what we're kind of talking about now, the evidence base.
Yeah, the evidence base. So the evidence base, someone comes out with a study that says a dozen sessions of CBT or, some particular type of therapy. CBT is the darling of the evidence-based crowd. Right. So a dozen CBT sessions, produce an effect size of, 0.34. And, patients, reported this much improvement, and clinicians said their global assessment of functioning, the GAF score went up. And so well, that's great. So what we now know is that in a 12-week epoch with these particular patients, and in the med trials, all of whom are cherry-picked, right?
Pre-selected.
Yep, right. And the pre-selection process in the med trials excludes pretty much everyone that would ever walk into my office.
Right. Anybody who is mentally ill. Yeah, you're right.
Right. Well, and and again, some of this is selection bias. So again, to be balanced in what I want to say, some of this is selection bias because now my role is only to see people I like to say they've been kicked out of every decent practice, and they have to come find us, right?
Right.
And they come find us because we do things differently. Because shockingly, we talk to people.
Yeah.
We offer therapy of various sorts. We offer neuromodulation, all these different things. Okay, talk to people about lifestyle things, right? But in those drug studies, like if a drug is being assessed for its efficacy in depression, then they will exclude people with OCD, people with bipolar disorder, people with various forms of anxiety, people with substance use. Pretty much everybody that comes to see me who has refractory depression has one or more of those things, oftentimes more than one of those things. And so again, applicability, how does that extrapolate from the study to the actual clinic where you meet people who didn't play by those rules?
Yeah.
And again, the drug trials, I mean,
It's not about playing by the rules necessarily. Like
Yeah,
they're presumably they're adhering to what you're
Right.
asking to do, but they just don't fit in the box.
yes,
They don't because
Yes.
this all assumes that these disorders, these diagnoses
Yes.
are discrete
yes,
pathologies. But if
Discrete.
everybody's got 5 of them, that obviously they're not.
It's-
The probability you have 5 independent neuropathologies
Right.
is almost winning the lottery.
Yeah.
And so, but that's kind of what science, what we're doing assumes that.
right.
So you only have to have depression, but not
Yes.
any other problems.
That's
which
right.
I imagine if you probably are not seeing very many of those people, like you said, because you're seeing the hard cases.
Yeah.
But I bet that for people that just have a little depression and no other issues, maybe these antidepressants probably are fairly effective.
That's what my good friend, I have I mentioned Dr. Kleinsteiber earlier,
Yeah.
the other younger Dr. Kleinsteiber, my good friend who has been one of my best friends since we were 7 years old and who I talk to on a regular basis still, who's an internist in Pittsburgh. And that's what he would tell you. He would tell you that he is in the role, 9 out of 10 prescriptions for psychotropics come from primary care doctors, not psychiatrists. That's another whole
Right.
can of worms. So they'll require another 2-hour podcast.
Probably, yeah.
But at the end of the day, he'll say just that, Andrew. He'll say that, he meets these people and they have, mild, it's depression. It's not just an adjustment disorder, whatever. They have mildly to moderately severe melancholic symptoms, and he'll give them these meds and they come back and say, Doc, that was great. Thank you for doing that. They take it for maybe several months or a year. They stop. They're on their merry way. But none of those type of people come see me anymore. I mean, maybe way back it went.
Right.
Yeah, but none
Because
now.
they've been
Yeah.
screened probably. Someone else has gotten to them with.
Correct.
So how did that, that's really what I've been wanting to get to. I think I didn't bring my watch. I think we've got probably in the second hour now.
15 minutes in.
Okay. So, you have a really just a fascinating, bundle of arrows in your quiver as a doctor. I mean, your office is a cool place for a brain nerd. And I'm curious, I'd love to talk about those specific interventions, but I'm really
Sure.
curious, how did you find yourself in this position of being the psychiatrist that people go to when psychiatry has failed them?
Yeah.
When they've tried psychiatry as it's conventionally practiced, didn't work, they find their way to your office.
Right.
How did you find yourself in that position?
Yeah. So I think that, that's a really, I like that question. How did I find myself in that position?
Like in the Forrest Gump
It's in the Forrest
tradition
Gump
that we
way.
have. Yeah.
Exactly. It feels like that. I think if Amy were sitting here with us, she would say, you can always count on the fact that Craig is the biggest nerd in the room, which is probably true.
Yeah.
Statistically speaking, maybe,
Yeah.
I put myself in the right position. I might be the second or third.
Depends on the
person.
room. Yeah.
Depends on the room.
If you're fortunate, you're not.
Yeah. And I have friends who would challenge me for that spot for sure. But I think that I just was always curious. I like to learn. Again, I hear my grandmother saying, be the eternal sophomore, and so I like to learn. And the other thing that happened is shocking, but you meet all these people who don't respond to the standard treatments. Even if you aren't necessarily, there isn't that referral selection bias that eventually evolved, in part because of people's needs, but also in part because of the managed care thing. That now funnels a lot of those people. Both of those factors funnel people our direction.
What are those two, selection bias and managed care?
Managed care meaning the sense that a lot of people are going to go to whoever their insurance company will pay for.
Right.
And, and they're going to get the shocking truth is that the average visit, I don't know if the listenership knows this, but the average visit time with the psychiatrist is 15 minutes. In primary care, it's 8 minutes. Now, I always say I find it hard to greet someone and sit down and initiate in 15 minutes.
Right.
that's a real challenge, and I've been doing it a long time.
Okay.
I know a lot about psychopharm. I honestly don't believe I could give someone proper care in 15 minutes.
Now, how often is that? Like 15 minutes per what period? The minimum 90 days?
Quarterly, usually.
Quarterly, yeah, because that's what the law requires. You
That's
see
what the
someone
law
every 90
requires.
days for a controlled.
That's right.
Okay, yeah, and
And
15 minutes is the probably bare minimum required by law to
Yeah.
write a controlled.
And
yeah,
and so you get an hour a year is another way of saying that.
yeah.
So, people say, oh, we're going to ration care or whatever. We're already rationing care. This
Yeah.
is like, this is a form of
Yep.
of rationing care.
Yep.
So I think that I saw a need in front of me. I encountered these people who didn't get better with standard, medical interventions, with psychotherapy. We were doing psychotherapy from the beginning.
Mm-hmm.
Probably the first thing that grew out of my perception of need in the patient population was group. I was reading about group and how group was preferentially effective for younger people. No shock, since they do everything in small
Yeah,
groups.
right.
Yeah. One of my best teachers, who was a psychologist, used to say, young people who go to traditional individual therapy learn how to relate well to middle-aged men and women.
That's an important skill to getting ahead. That's who decides if you get to go to the school or have that job. Or like that. I imagine
Yes.
there are probably a lot of people that Dr. Patty works with that just don't have that skill, and that's how they end up ensnared by whatever. So I think there's some profound truth to that.
Exactly. Not to diminish that.
Yeah, but it's also like, you're learning how to have 40-year-old relational skills and
Right.
practice nonviolent communication as a fourth grader, and
Right.
exactly,
And then everything you do is a cohort based, right? As you grow and mature, and so group makes sense. And I've always found that group. With a handful of important exceptions, I've seen some little children for group, and I've seen some teenagers who I think really did do well in individual therapy, but they usually will definitely return on investment wise. It's group is the thing, and then along came there were these ideas about neuromodulation and TMS, in particular. Neurofeedback has been there for forever. It's not neither of those things are really new, but their application in clinical medicine is relatively recent. And people would ask me for years about neurofeedback. They wanted their children to receive neurofeedback, and I always said interesting but unproven. And one of the challenges was there was no ability to take a quantitative EEG and have a fully human database. I know this sounds ridiculous, but some of the early databases had rat and monkey brain data in them.
Right.
And so this guy, Bob Thatcher in Florida, was the first person to really get through the FDA a comparative database that was appropriate and applicable. And that happened in 2012. And
When you say comparative database, you're meaning among different patients, not the same patient over different times.
Correct.
Yep. Okay.
Yeah, got together. I think if I forget the exact number, it was like 1,000 patients, and did these quantitative EEGs and established, there's a very broad range of what's typical, right? And so that you don't, conflate a typical variation with something that truly is outside the norm, maybe normal. That's by statistical means. Again, there are shortcomings and all that too.
But
it allowed neurofeedback in my mind to have validity, because you could say, well, that isn't just, hey, Andrew has studied yoga, and so he's got a particular, his alpha frequency is more prominent than Craig's, who didn't, or whatever. I have a fun story about that with a songwriter, but we'll get to that another time.
Okay.
But anyway, so neurofeedback in 2012, when that database was approved, we started our neurofeedback program. And then a few years before that, one of my partners was the first person in Middle Tennessee to have a TMS machine. And it was approved in 2008, and in 2009, I started using it.
TMS?
Transcranial magnetic stimulation, modulating the neural network with a magnet.
Okay, cool. And you had a friend that had one, and you had to check it out.
Yeah, my partner.
Of course you did. Yeah.
I'm back there like, what's that?
Yeah.
It's like,
And I'm hearing you talk about this, and you started off by saying you're a nerd, and I'm like, this stuff's all really cool. Like, it's really cool stuff. Like, you got some cool equipment,
Just a fellow nerd, Andrew.
Right. No, I get it. I'm like, of course, it makes sense that you basically were like, that's how I am with cameras. Like in technology, I'm just like, I wonder what this thing does. I want to get this toy to play with. And then eventually people are like, hey, will you photograph my whatever? And I'm like, I'm not qualified to do that, but I really I'm just going to nerd out about it anyway. So I may as well get paid for it. And it's kind of like I wouldn't say it's a Forrest Gump way of finding your way into it.
Yeah.
But it's a good way,
Yes.
So you've had neurofeedback and TMS were about the same time that they became clinical.
So I'm trying to think about the timing of that. I think we started our I started using TMS with my patients about 2009-ish, somewhere in there, late 2008. It was approved in March of 2008.
Okay.
And around about that time, a little later, I started using it. And then neurofeedback in 2012. And that was really tied into, there's really a convergence of things with neurofeedback. One was the availability of the computing power to crunch the numbers outside of a mainframe.
Okay.
And that we had, I'll never forget, we went into Best Buy to get our first neurofeedback computer, and I'm asking this guy about these gaming computers.
Right.
And
That's what
he's
you want
looking
for
at me, he's like, dude, you're into gaming. I'm like, well,
No.
not really.
Yeah, no, I got to crunch brain data.
I got to crunch
So let's
brain data.
let's dive into each of these because
Yeah.
I'm deeply fascinated by them. Let's start with neurofeedback.
Sure.
What is that?
Yeah, so neurofeedback is a specialized form of biofeedback where basically we, at baseline, we take a sample of your brainwave activity using a traditional EEG, but we quantify that data. That's the name, quantitative EEG.
Yeah.
And
What is EEG?
electroencephalography. So taking a tracing of the brain's electrical activity, and it's usually done with these 21 lead devices. And what we're really looking for when we do that, well, and I should also clarify, quantitative versus qualitative. I'm old enough that I remember when I was starting down that combined path, we would go in the morning and there would be, you guys are too young to remember the bifold computer paper with the edges that you
I
tear the
remember in
strips.
my grandmother's office
Yes.
when I was a little kid.
Yes.
Yeah, I'd play with it.
Exactly.
You play with the edges. Yeah.
Tear the edges off.
Yeah.
Yeah. So there would be these bifold computer things where the tracing had been done, and then the tech, who they were usually pretty astute because they'd seen hundreds and hundreds of these, and they knew what it should look like and what it shouldn't, would put sticky tabs, like little yellow sticky tabs, and then you'd flip through and go, oh well, no, that was limb movement, or that was oral. That's actually some sort of epileptiform activity, or geez, there's some global slowing here. The person has a metabolic disorder, or whatever. So you were qualitatively assessing the tracing. Quantization is really primarily phase, frequency, amplitude, and coherence, but you can use other mathematical methods to derive additional data about brain connectivity and function from those primary indices, right? And you can compare this to a normed database and say, not are there differences between our EEGs, because we have different genetics, we have different experiences that sculpted our brain connectivity, and so of course they're going to be different. But the question is, are they different in ways that would truly be statistical outliers? And if so, is that statistical outlying activity or connectivity or lack thereof, you mentioned like synchronization of brain activity,
Right.
brain networks synchronized in certain ways for certain functions. Is that something that would lie outside the developmental norm defined as plus or minus 2 standard deviations from the mean?
Right.
And if so, is it in a part of the brain that we would expect to correlate with this person's particular profile? This is a huge thing. And again, not to be too self-serving, but a word of caution, I think, because this is unregulated, you can just kind of do this. You can buy the machine and set up a clinic and go to a little weekend seminar at Opryland. Yeah.
Right.
What do you call
Really?
that?
Yeah. Opryland. Right. All right. Yeah.
Wherever.
Go to Dollywood or whatever you got to do.
Wherever
Yeah.
you
To the
gotta
wax
do.
museum and get certified in brain neurofeedback.
Exactly.
Okay.
And so, this is where being a good clinician comes in, because it's not just, is the activity abnormal? It's, is the activity abnormal in a way that's salient to what the person needs help with? And also understanding some people may have activity that's abnormal that's a result of their life experience or their path. This is the songwriter I was telling you about. A songwriter who came to me and was doing neurofeedback with a different practice, and he said, is it possible that it's making me worse? And I said, well, if it works, there's got to be a possibility it can make you worse. What's going on? He's like, well, I have writer's block.
Interesting. Interesting.
And I was like, well, bring me your stuff. And so he brings me his quantitative EEG, and I look at it, and it's like, there it is back here in the association cortex on the left. He's got all this high beta activity. Well, of course he does. This is where you would expect high activity in a right-handed person who's, developed this particular skill. And so he had lost his ability to write songs as a result of downtraining there. And he'd been told, like, oh, you've been misdiagnosed with ADHD, you actually have anxiety, and if we downtrain this, you'll have less anxiety and you'll feel better. Well, it didn't do anything for his ADHD, but it did shut down his ability to write songs.
Right.
which is a fascinating thing, sort of talk about a proof of principle.
Right.
Yeah.
Yeah.
And also one of my pet peeves is neurofeedback clinics that say there are no side effects. That's foolishness. If you're manipulating someone's neural connectivity, there must be the risk of side effects, right?
But I think side effects is kind of a contrivance.
Yes.
It's an effect.
It's an effect.
It's just the one you're not paying for.
Exactly.
You know what I mean? That's basically like
An
that's
undesirable
the only
effect.
right. Yeah. I mean, that's it. It's an effect.
Exactly.
Yeah. I mean, I've taken amphetamines for so many years. I know that there's like the side effects. I'm like, it's a central effect of amphetamine that it's going to make you a little jittery and like, it will
Absolutely.
suppress appetite, which may be an effect or a side effect depending on how the drug is packaged. Right? I mean, it's like
Right.
if it's a weight loss drug and it's mama's little helper,
Right.
it's a great deal if it help you
Obitrol.
lose weight, right? Is that what the original was?
Yeah.
Obitrol.
Yeah, amphetamine was originally marketed, actually Adderall was originally marketed in the 70s, I think, as Obitrol.
Okay.
And it got pulled not because of safety, but because of efficacy, because most people acclimate.
It was as a weight loss drug.
As a weight
That's
loss
what-
drug,
Right,
yeah.
right. So
Obesity
now
troll.
it's a side effect.
Now it's a side
that,
effect.
that it will suppress your appetite, even though you won't lose weight. So,
Yes.
So with neurofeedback, I mean, as I understand it, so you've got these leads on your scalp, and they're
Right.
measuring brainwave activity through the scalp. I talked with Dr. Rosenthal about this because
Yes.
he does intraoperative monitoring. He was actually monitoring a brain surgery on a monitor while I did my interview with him, which is fascinating. And he's looking at EEG data and just different parts of the brain, and so he's obviously got the benefit of doing that from inside the skull.
Right.
I think, which is you're not going to cut up in someone's skull for ADD.
Deeper, right.
Yeah. But so you've got these different brainwave frequencies you're reading. I think I remember they're alpha, beta, delta, and theta.
That's right.
And they have different associations for different kind of activity.
Right.
You said it was high beta in his.
He had high beta back in his association cortex.
And that would be associated with anxiety, right? Like
Could
when
be.
you think high beta, but in this character, in this person, it was
It was a trained skill.
a skill. You think it was a result of like a deep focus, kind of almost.
Yeah, it's like saying maybe Roger Federer has an extraordinary motor cortex.
It's interesting.
Yeah.
It probably does.
I'm sure he
and it
does,
probably
yeah.
was born with that
That's
and
right.
then has developed it
That's
from an
right.
early age. And so
That's exactly right.
But I was thinking, interesting of having high beta associated with creative expression. For me, what I've noticed as I've really the recognition that I'm an artist, I'm a creative person, and like, oh, that was what was missing. I've always known something was missing. I thought it was something wrong with me, and really it was just that I wasn't around creative people and I wasn't creating.
Yes.
There's a sense of a pressure to get it out. That's how it feels like. It's like there's something in my head, and I need to.
Yes.
I have to get it out.
Yes.
And it almost is kind of an anxious feeling.
Yes.
Almost like an akathesic feeling. Like if I don't move on it,
Yes.
I'll go crazy. I'll
Yes.
go nuts. And it's interesting that it would be probably a high beta, like that push of like I have to do something right
Yes.
now, and I'll feel better if I can show the world what I see through the lens of this camera.
Yes.
Yeah.
And you said earlier if therapy is art is therapy, and
Yeah.
it's like
Yeah.
this interchangeable. It's as someone
is.
who's married to an artist, my wife describes this. Like she literally will get pent up energy to the point like she has to do something creative. She feels like she has to release it.
Yep.
And I would argue after all these years that that's therapeutic.
Of course.
And like one of of course, in the corporate world, in the early season of my life, I directed an inpatient unit, right?
Okay.
And I worked for HCA briefly. And again, HCA has done a lot of good in the world, so this is not like throw shade on HCA. But the dynamics between the administration and the clinical leadership about what should go on. And one of the first things they wanted to do when managed care come along and they started to, cut payments and all these things, can we get rid of the music therapist? Can we get rid of the art therapist?
Right.
And my response at the time was, no, because there are people for whom, and this is even more common in younger people, they don't have that's what I'm looking for, the facility with language to really process what's going on with them.
Right.
But you put them in front of an easel, or you give them some clay, or you teach them to play a few chords on the guitar, and all of a sudden these amazing things come out.
Yeah.
Okay.
Yeah.
And it's so this release is therapeutic, right?
Yeah. Well, I mean, I would say the absence of that release is the whole reason for the needing the therapy. Really, it's just that like there's this something is wrongness feeling I've noticed has gone away. I started a little film program here, and just having other people to talk about movies with. I mean, my level of neuroticism plummeted. Just the sense in my body that I was sick, something was injured, whatever. Like I had all this bodily issue, not dysmorphia, but it was just like a sense of dread about being sick all the time. And it went away within a week of just film studies, and I was just like, this is what I'm supposed to do, and the idea that I might be able to actually make something. Film takes a long time to make, and I still want to make at least a movie, some movies, but I'm working on it. Photography is a much faster turnaround, and it's a simpler setup, and there's sometimes it can be more profound. But I've got multiple art forms now that I can get out, and
you've got a great eye,
yeah. My sense, it's really it's because of neurofeedback. I like neurofeedback changed my life because the feedback I got was a movie.
Yes.
and there's a screen and it will shrink at the edges, and it's not a crop. So like the whole screen would shrink, which is weird because the image gets smaller. And it becomes like a game. I understand neurofeedback for children a lot is like a game, and there's a frog or something he's got to eat.
You
whatever.
can do it that way.
Yeah,
yes.
It's goal oriented almost.
Yeah.
So there's a little reward.
That's
like
right.
There's this dopamine when you do the thing. And
Yes.
for me, I'm just trying to get the screen to go out. So like that was my neurofeedback, and it. I think as a result of it, I think I did 30 sessions. I think it is objectively true that I can pay better attention to a movie than anything else. Like I am more mindful and in the moment because I've trained my brain when I'm looking at a screen. And another thing that changed is most people, when they watch a movie or television, they just kind of zone out, but they're listening, they're engaged in the story, but they're not visually engaged. And a lot of like Netflix, for example, is actually pushing creators to make this what's ever on the screen not important, and to restate the plot because they expect people to be here.
Oh my
And
goodness!
so they want their screen. They say it's not second screen enough. Is what it's called.
Why am I not surprised?
They want their screen to be the second screen, and they want it to just be playing. So that's not how cinema was ever designed. It's a photographic art, and the meaning really should start with the image. And there's this ethic of every frame a painting. A movie is a series of individual still photographs, frames, played back at 24 frames per second, and that gives this illusion of motion. And when you add sound, it's very immersive. But you should be able to pause a movie at any point randomly, and whatever frame you see should be like a painting. That is, for me, the standard that I would want to go for as a filmmaker, because when we lost that, people said that when the talkies came out, it ruined cinema. That was the doomers were saying. And I think they were kind of right. As it existed, cinema was an international language because it was an international art form because there was no language barrier.
Sure.
You would see text or whatever, but it wouldn't be coming out. It would be the dun, 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 and then it would be the thing of what this guy said after you see the action.
Yes.
So everybody in the world who saw it had the exact same experience. And now, as you probably understand from working with things like language disorders, there's a difference between the words and the meaning we make of those words, and that makes translation and art, but there's a little bit of a drift semantically with when you're translating from one language to another. If I watch a Japanese film, there's just cultural differences that are not going to make it. But yeah, the image. So now, like a lot of people kind of dead eye in the center of the screen, or they're looking at, you don't realize there's fascinating studies on eye movement tracing that neuroscientists can do.
Absolutely.
Well, it's fascinating what people do with their eyes when they're watching movies, and there are autism studies, I think, involving this. One of them was done on a movie called Who's Afraid of Virginia Woolf? Have you ever seen this film?
I'm familiar. I don't think I've seen it. I know the title. Yeah.
It is one of the best films I've ever seen. I think it was Sidney Lumet, and it was a play. It was very stagey, but it had Elizabeth Taylor, probably one of the best performances I've ever seen. And she's this wife, and she's got this husband who's an academic, and then there's two young academics that are there after a party. They're all drunk. They don't need to be drinking anymore. And this marriage is just, these people are all miserable. They're miserable to each other. They're drunks. And it's a really amazing play, but there's a moment in it where he comes and opens, he pulls something out, and you think it's a rifle in the middle of this fight or whatever, but it's an umbrella, and there's this surprise. And apparently people with certain neurodevelopmental disorders don't register. They don't understand what's surprising about it, because then you can tell their eyes are off somewhere else. And so that's a fascinating science with cinema. You can manipulate where people are looking. But I started looking at the image from the outside in instead of from the inside out. And there's a zooming out feeling. And that's really how meditation works for me. It's photography and cinema for me are a meditative practice.
Absolutely.
It's a practice in being present with how you feel and what you're noticing. And it started with looking at the edges of the frame and then realizing, there's black bars up here on some of them, but not all of them. And the black bars are different sizes. What the hell is that about? Why? And there's a technical answer to that, and there's a creative answer to that.
Right.
But that's how it started for me, was nerding out and like, why do I care that Oppenheimer's on film? Like, why do I care that I see that? What difference does that make? And it's kind of how I got into it, the way you did with the neurofeedback and the TMS, of just being like, this is cool stuff, but is it there yet? Like, is it there for my practice? So
Yeah.
that was my digression on what neurofeedback has done for me. It's like,
Yeah.
I can pay attention now.
It's
context
interesting
dependent.
too, and that again, like that probably eventually that would extrapolate outside, but initially for a lot of people, again, you expect that the skill is going to be most accessible under the circumstances that most closely approximate the environment in which it happened, right?
Yeah.
And then over time it can extrapolate, but the underlying premise, operant conditioning, people say, oh, I don't know about operant conditioning. Is this really, it's just,
Right.
and again, I think it's like so many things, back to humility and knowing the limitations and not being a salesman to someone about something that you're doing, but presenting it in a very balanced way.
Right.
And so neurofeedback, obviously it's not a panacea. It doesn't work for everyone. There are people who, for whatever reason, it's not highly effective or effective at all for that matter. But it's very reliably effective. And it's very safe. As things go, especially if it's implemented by somebody who actually knows you,
Right,
as
right.
opposed to looking at your checklist and then down-training your beta that made you a songwriter.
Right.
But sorry, that's a little salty part.
Perhaps that could be a very immensely profitable skill too for some people, and to lose that, like, that's a big problem. I get
Yes.
it. Like, especially if you're one of the few people who are fortunate enough to earn any living from your art, which is a vanishingly small number of people.
Well, we're here in Nashville, so in the interest of privacy, we won't go any further than
Sure,
we have.
sure,
But
but
let's just say that this person wasn't doing it on an amateur level. How's
Sure,
that?
yeah. It's
Right.
here. This is one of the weird things where you meet people and you're like, well, holy shit, this person has Grammys, and they're just this guy that I met. But I can relate to that on a soul level though, to lose that ability. Like, gosh, that's a grief process you have to go through at that point, and so it is important. Like, that's why I wouldn't want just some person mess with my brain. You know what I mean? Like, the brain is a terrible thing to let someone experiment with.
Yeah. And so the operant conditioning model, Eric Kandel won the Nobel back in 2000, early 2000, 2001, somewhere near 2003, for demonstrating in a very simple organism how operant conditioning works. And basically environmental stimulation causes the neuron to bud and to grow new connectivity, which is the physical substrate of learning. And so it's not surprising that younger people tend to get better results as a result of that. The neuroplasticity of the human brain peaks between the ages of 4 and 12. So that's your ideal neurofeedback candidate. But, we've trained people successfully my own age and beyond. In fact, we had one lady who had a very unfortunate incident where she suffered a bifrontal head trauma and was just severely impaired from that, and it had a long course of neurofeedback, but did really, really well with it. But again, it doesn't work for everyone. And I think a huge part of it is the person doing it, number one, are they qualified to understand the big picture? And number two, are they actually monitoring you? Are they seeing you? Are they asking, is this, because the protocol isn't set in stone. The protocol is my best guess with the consultation of someone who's been doing it for 45 years based in Minnesota. It's my best guess about what's most likely to be helpful for you individually. But again, then on an individual basis, it may or may not be. And sometimes we have people start down a path and they'll say, hey, if anything, I think things are worse. Well, let's stop. Let's back off.
Yeah.
How's it worse? Because that's another thing. Like,
right. Well, that's information too that could be revealing, right? Yeah, that's just
Absolutely.
as obvious to me that I'd be curious to know.
Right.
I've had situations where I've been talking to physicians, and I tell them, I took this drug and this thing happened, and they'll go, that can't be right. That's not how that works. And I'm like, what do you mean? I'm the data. You can't reject the data. You know what I mean? Like, what do you? It's just like, but it's like, I'm blind now. I'm not making this up. I never went blind, but it was just like, no, that can't be that. You can't be right. Like, it's hysterical. And it's just like, I don't know why you would want to reject the data, but for some people, I think that some people definitely seem to have a higher tolerance for complexity than others.
Yeah, I think it's, and we may have talked about this in the past, but I really do think like that what between the 15-minute visit and the pressure to see more people and the declining sort of like, there was a time when I think doctors were held in very high esteem. And between all those factors kind of come into play and people feel defensive. And there's really nothing to feel defensive about. Like, I mean, one of my favorite memories from school was for my first day of psychopharm, the professor said, you know, the classic, if you only remember one thing, right?
Okay.
And then he said, any drug can do anything to anyone at any time. And I remember thinking, well, that's helpful.
What a way to narrow it down. Yeah.
Right.
Right.
That's
Yeah.
the most useless thing anyone's ever said.
Right.
And then, of course, like so many things, when you hear them when you're naive, and then 37 years of clinical experience later, I can say, that guy, he had it going on. He understood, because the truth of it is like the side effect that you experience may be an uncommon side effect. We may not readily have an explanation of why that drug would cause that side effect. But if we are observing it, again, it's back to the anti-science. Here's something that, you know, and like, no, that's impossible.
Yeah, it's not even unscientific. It's anti-scientific.
Yes. To the Tower of Galileo.
Well, the point of, I've made this point before too, that like in a lot of things that I've seen with psychiatry, it seems almost anti-scientific, or I would say pseudoscientific. But that the point of science is to try to prove yourself wrong. It's a technology to promote intellectual honesty.
Yes.
Right. To know that when you're wrong. Right. And I've had many experiences where it seemed like it was almost designed to prevent that, because the diagnoses are all subjective. There's no way you can really prove one wrong. And then when you have that lack of construct validity and the unfalsifiability, and there's another number of other kind of factors there that make it that so, but it really just kind of depends on, you make a good point. And something I haven't actually thought of is that I think that some people who are physicians, probably all people definitely, but people are insecure sometimes, and people can get defensive, and that's a natural human response to being questioned. And also because of things like the internet, WebMD, but now ChatGPT, I'm sure is an increasing problem. Speaking of, I need to ask, I've been hearing more and more about AI psychosis. Yes. Are you informed about this? Are you hearing anything about this?
I don't think I really know a whole ton about it. That the AI itself develops psychosis?
No, that it's inducing psychosis in humans who are using it.
Well, I know for sure that it'll do fun things like tell meth addicts, like, well, given what you've told me today, I mean, maybe a little meth wouldn't be the world's worst idea.
Right.
And I think
because meth addicts have notoriously good judgment.
Right. I mean, just a little. Don't do
just do a little meth. That's like shit. Why didn't that occur to me?
How do you define a little?
My God. Yeah. Right. Yeah. Exactly.
You're doing a lot of meth.
Right. God, all this time I just needed to do less.
1/4 is
just so simple.
Do.
Yeah.
Right. Is that a little?
That's funny. Yeah. That's scary, but it shouldn't be funny, but it is.
Well, and again, like back to the technology and the strange medicine and commerce business were strange bedfellows. And I love telling the story of one of my colleagues who's a lovely guy, a very bright guy, straight out of fellowship. He went to let's say a rural area. Okay. We don't want anybody to be able to deduce who this is. But he went to a rural area and set up practice, and he was the only child doctor within literally hundreds of miles. And of course, immediately there's an enormous need for child. Okay. And so, I mean, he was, full to the gills and beyond, and was working a tremendous amount of money, or a tremendous amount of time, making a tremendous amount of money. He's from a modest background as well. His parents were not well-to-do. He bought his mom a house. He did all these things. Lovely things to do, but he neglected to pay his federal taxes. Okay. And when he told me this story, I said, what do you mean you didn't pay your taxes? What are you talking about? And he's like, well, I thought they were taking it out. And I was like, dude, you're self-employed.
Yeah,
like,
who's they? Yeah, who's they? Yeah, yeah,
You're the they.
Right. Yeah.
And so, luckily he was able to, work with the IRS and get right with the Lord and all that good stuff. But the reason I tell that story is because that's how little business education most doctors have.
Right.
Like he literally didn't understand that taxes were going to come due after his first year.
Right.
And he was it wasn't like he was out spendthrifting these things. He bought his mom a house.
Right.
Nice thing to do. But he had been so irresponsible from a business standpoint that he put himself in this tremendous hole with the tax man. Right. And so again, I think unfortunately these things have come together in a way that's really problematic, and that things are being sold if that makes sense.
Yes, it's
yeah.
it's it's like almost a consulting model where a consultant has a series of products they can sell you, and they want to upsell you, and
Yes.
that's where the profit is coming from. It's like, what can
Yes.
can I sell you on this thing? Because this one treatment I have may have very high margins. You know what I mean?
Oh,
like that's the decisions I know that at a corporate level, that is what's
yes.
going into it.
No. I mean,
Gotta be.
people. I mean, so people ask me, and I try not to be because I know they're not asking it with malice. But people will say, "Are you a TMS clinic?" And I'll say, "No, we're a clinic that can offer you TMS if you need it."
Right.
And a friend, we won't just a friend has a son who's in this world, and so I've had very candid conversations with him. I mean, TMS clinics, if it says TMS clinic, as my grandmother used to tell me, if you go to the barbershop, you get your hair cut.
Right.
And so
Right.
they're trying to get as many butts in TMS seats as they possibly can.
Right.
And I'm not saying that they don't do great things. I'm for sure lots of people have had effective. TMS is a highly effective treatment. So probably a lot of people have had life-changing experiences at TMS clinics. But I'm also willing to bet you that a disproportionate number of people were put under the TMS helmet who probably it wasn't necessarily the best right choice, but it was more of a commercial decision to put that patient in that particular path.
And so these things were extant before you adopted them.
Right.
You were waiting for an evidentiary basis. Now, and that's also happened with a new treatment recently too, also with Spravato, right?
Yeah,
That had been
esketamine
with
or
ketamine.
Spravato, yeah.
So I'd like to let's go there then, and I'd also like to talk about what TMS is because that's the transcranial neuromod. But so Spravato's come out, and that's the brand name for esketamine, right?
Esketamine intranasally administered.
And people have been going to ketamine clinics for 20 years now, right?
Ever and ever.
Yeah. I've heard of it as it's being kind of branded somewhat with psychedelic medicine, even though it's not. I mean, it's not a psychedelic medicine, but they're I guess they're biologically completely different. But I just think there's a demand for psychedelic medicine, so it's advantageous if you're in the business of running a ketamine clinic. But the interesting thing is, if you're only just adopting it now as a psychiatrist, why have people been allowed to do it for 20 or 30 years? How did that transpire?
Again, you said earlier about the expansion. I joked, I gave you the air quote expansion of the indication.
Yeah.
You said expansion of the
Market. Yeah.
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 Well, and again, one of my things in life is be balanced and approach with grace and the compassion and like the idea that I think doctors are oftentimes presented with very difficult circumstances and patients who literally, in the case of esketamine and ketamine therapy historically, the population that was most likely to receive that kind of treatment was a population of people who were acutely suicidal.
Okay.
And the reason that particular population was targeted was treatment refractory, defined as have failed to respond to ordinary treatments. And then people who were acutely suicidal. And the acutely suicidal person poses an especially problematic risk, right? Because we do deal with people who are absolutely convinced that the best thing they can do is kill themselves.
Okay.
And a lot of them have plans to kill themselves at some level or another, and they have means. And it's not comforting to hear as a family member, but there's really not a lot the doctor can do about it if someone decides that they're going to kill themselves. People have killed themselves in padded rooms in state hospitals and run their head into the wall and broken their neck. And so you can see if someone's really dedicated to that. So you have this sense of urgency, obviously, for these people. If someone's sharing this, then you want to intervene. And at the time, there are very few things that work quickly. In the quickly working category, we have esketamine or ketamine. We have ECT, electroconvulsive therapy, and there's a newer drug called Auvelity that's relatively new to the market that seems to work a little bit more quickly. But there just aren't really that many.
What class of drug is Auvelity? Do we know what it is?
Let's see, Auvelity. I'm blocking right now, my friend.
Okay. All right. But it's something that would be administered by like an EMT?
Oh, no. No. It's a oral antidepressant medication, and I'm blocking about the particular receptor subcomplex that it works on. It'll come to me if I don't try to think of it.
Yeah,
you can edit this
you'll
out.
think of it 2 hours from now.
While I think of it, we can fix
Yeah.
this. But it works on this in a unique way. So even if you failed multiple other SSRIs, SNRIs, you've had TMS for that matter, because all those are mechanistically different from the mechanism of action of Auvelity. And likewise, as ketamine, it works differently in the body and in the brain. So for that reason, it's thought of as a novel trial, an independent trial, apart from other things that you've done, right?
Right.
So that's esketamine. Again, it doesn't work for everyone. The results are generally pretty good. It does require ongoing maintenance treatment for most people. So if you respond, the effect of the drug is not durable over a long period of time. So you were saying like some of the psychotropics, you have this perfect business model of like, stop
It's a drug that never cures anybody. Yeah, it makes you sick and you stop.
Yeah. And again, to be balanced about that, I would say that's the case with hypertension and cardiovascular disease,
statins.
cholesterol, statins,
Yep.
all the above.
Yeah.
And so I think that is its role. So you said if it's been around forever, why did it take Craig Clark
because
so long?
you're telling me a lot about the psychiatry of it, but we've been using ketamine for a long time before it was used for mental health.
Anesthesia.
Right? Yeah, anesthesia.
Yeah.
Child dental surgery, I think, right? Like
Yes.
for children is considered mild enough for children.
That's right.
Yeah,
that's right.
And why is it effective for a child dental surgery? Why would you?
Well,
what are the benefits of it as an anesthetic?
Yeah, it induces this sort of relaxed, disassociated kind of feeling.
Right.
And just people will say they feel floaty, or they're kind of like there, but nothing's really troubling them too much. And
this is in a conscious waking state.
That's right.
Too, right? So I guess there's some surgeries where people need to be awake as well.
That's
And
right.
I imagine ketamine would, I suppose, be helpful. Brain surgeries like that, right?
that's right. They use it in certain types of surgery like that.
Have you ever been in the room for brain surgeries?
I have
Weight
been,
craniotomy?
yeah. I've been in the neuro suite back in training. It's a crazy thing to see,
Yeah.
the burr hole, and there's the brain sitting
Yeah,
there, and,
yeah.
and they're stimulating different parts of the brain. They're
And
getting
then movements.
Yes.
Yeah.
The context that I saw that was surgery for intractable epilepsy.
Right.
And so they're mapping out where they're going to cut.
That's
to
what
try to
I talked
minimize.
with Dr. Rosenthal about
Yeah,
a couple of weeks
yeah,
ago because we talked to it's so interesting. Epilepsy is an interesting thing because there's that connection. I think it was David Baer that is interested in the study, the intersection of epilepsy and psychiatry. I mean, it was very surprising when I learned that one of the main classes of drugs you would use for bipolar disorder would be anticonvulsants.
That's right.
What the hell is the connection? And nobody knows. But and then there's this ketogenic diet that comes in that's definitely anticonvulsant, and that may have applications. But temporal lobe epilepsy, really fascinating thing. And we talked about the split brain phenomenon, which is people who've had like a radical cholecystectomy that they sever the left and right parts of the brain, and that's it's just a fascinating thing. Do you have patients that have a co-occurring epilepsy with psychiatric disorders? Is that common?
Very commonly.
Yeah.
That flows both directions.
Really?
So if you have epilepsy, you're way more likely to have some variety of psychiatric challenge, and likewise, if you are someone who's affected by depression, anxiety, ADD, whatever, both directly and indirectly, a lot of the ADD crowd have abnormal EEGs because of trauma. They are more likely to do impulsive things and take a blow to the head.
Okay.
And so
because of head trauma, brain trauma. Yeah.
Brain trauma.
Right.
Like
right.
Physical.
And can you see that on an EEG? It's just there's a specific area where activity would be low or abnormal.
Yeah. Like slowing in that part of the brain, or certain patterns of connectivity disturbance that are known. There's a Department of Defense database that actually compares the patient that you submit a sample of Craig's brainwave, and it compares it to the database and says how closely does it approximate those things.
So earlier we were talking about I mentioned HIPAA.
Yes.
Right? HIPAA balkanizes your information, so there's no way to map. This is one advantage I think China has over the United States because there's no privacy there. They definitely don't have HIPAA. That's hysterical.
Right.
But they can study the whole population. With their quantum computing and things like that, big data. And I assume that the reason you're going to the Department of Defense, they have a lot of head trauma, but they're also probably not subject to HIPAA. Like they can anonymize and aggregate their data without needing individual sign off. Because it's by joining the military, you probably sign away your privacy rights in medicine or to get your benefits from the VA.
Yeah, that's interesting. I hadn't thought about that, but I'm sure that's true. And I know you can buy into using that or not.
Right.
You don't have to use it.
Some MBA probably from Vanderbilt got them to license that data out, which is good business. But I think that's a challenge. We were talking about EEGs with brain injuries. Right. Is EEG effective as a diagnostic tool?
Well, there are limitations to it. Again, see, I think this is the other thing is like people will say to me like, oh, well, ChatGPT told me that this doesn't diagnose anything. And I'm
I can
like,
say
well,
ChatGPT told me it's been making people psychotic. So like, you know,
well, yeah, we could throw you. So, oh, and I left a hanging chat on
okay,
that.
okay,
Let's just
yeah,
very quickly do that.
okay,
And we'll talk about does it diagnose brain
okay,
trauma or
yeah,
ADD or whatever. And the answer is it doesn't.
okay,
But the short answer. But what ChatGPT told me. One of my patients who is a very high level computer dude. I mean, he's in cybersecurity at a level like where let's keep the terrorists from flooding the Tennessee Valley,
got
that
it,
kind
yeah,
of stuff.
okay, yeah,
But that isn't what he does. Just to be clear, dear
right,
listeners, I'm
right,
not
okay,
giving away
yeah,
identity, but it's that kind of
yeah,
stuff. Okay. And so he told me that he said, ChatGPT, again, the blend of commercialism and medicine and all these things, ChatGPT will tell you what you want to hear as it perceives it. So depending on what you've said to it in the past, what you've asked it about, what you've tapped on and searched, there's an algorithm there. We were joking about the algorithm as we walked in here today,
yeah,
right? And so there's an algorithm there, and it will direct its answers in a particular way. So he said, if you really want anything helpful from ChatGPT, you have to say, please don't fluff me here.
right.
Like just
I've had to tell that many times, and
yes,
I've gotten
yeah,
where I only use it as my assistant cinematographer. Like
yeah,
I only ask it for technical.
yes,
You know, I do use Claude, which is Anthropic's AI,
yeah,
because its verbal reasoning skills are noticeably better. It's the best. And if you think about which component of intelligence is most relevant to EQ, it's
right,
going to be that.
absolutely,
But I also have instructed it, and from the beginning, I was like, look, I'm going to use you for this
yes,
purpose. If you tell it what role to play
right,
and say, don't kiss my ass,
yeah,
like, I'd like you to play the role of
yeah,
a forensic psychologist. Tell me to figure out why this did, or play the role of a career coach, or play the role of a friend who's here to keep me accountable.
right,
There are ways to do it. You have to prompt it, but you also have to be interested in intellectual honesty, which is like, that's a radical selection there, right? I mean, a lot of people maybe are just using it as a friend or someone to make them feel better, which is also specifically not what therapy is either. And that's a whole
absolutely.
problem, right? Like they're
Oh,
using it
oh,
as their therapist, but
it's a
it's also
bad
going, just use
therapist.
a little meth.
It's a bad
Right. It's
therapist.
a sycophant.
Yeah,
Yeah.
it's a sycophant.
Yeah.
That's a great way of saying it. And again, you asked me how I introduced myself at parties, and I said in my, later parts of my career, I introduced myself as a professional, difficult conversation haver.
Yeah.
Like, if I'm doing my role well, I'm going to have difficult conversations with people. But that doesn't mean that they're unpleasant or unkind. It just means they're difficult,
Yeah.
right? If you really care about someone's development as a human being, you're invested in them, then you will say the hard things.
Yeah.
It's like I joke all the time. My wife Amy taught me none of us are perfect observers of ourselves, and someone that really cares about you and who's willing to reflect back to you things that you need to see, that, in my opinion, is one of the deepest, truest forms of love. It's like I'm invested in you in a way that I'll do the hard things with and for you.
That's profound. In my own, like my personal growth practice now, I'm working with Laura, the neuroshamanic healer, and she's got this new curriculum that she's put together called the Neuroshamanic Path, and it's to train people in some of her practices. And really just the intersection of neuroscience and shamanism, and a lot of it involves brainwave activity and the way we respond to drumming, and that induces theta
Absolutely.
states. And
Absolutely.
and
That vagus nerve is activated. Chanting.
chanting,
Yes,
yeah. So
yes,
you
yes,
mentioned brainwave entrainment between
Right,
people, and I think
right.
harmonies, like
Yes.
that's literally what you've
Yeah.
got, entrainment of sound and of brainwave. And I also think that's probably related to what spirituality is. You
Yep.
mentioned the placebo effect, and like we have this desire to be cared for and to be part of a tribe, to be part of something bigger.
Absolutely.
There's a dark side to that too, which is tribal violence and hatred. But I think when the ego becomes a superego, when the ego dissolves and merges into something bigger, greater than ourselves, that's, I think, the definition of, that's what transcends all religious. And there's some precedent for that. I've got some people I want to talk to about that, but I would also love to do my graduate study on it. But Laura I'm doing some mentoring with her because she's told me, like, I see you as being a healer, someone who can implement these practices and help people. And I don't see myself that way, but I also, for a long time, haven't really seen myself as particularly masculine, which I tell people that, and they're like, because I'm like, I do have a beard, but like, whatever. I mean, and just, there's a lot of things that I don't see myself as. And I've said for many years, I think I first said this to myself 10 years ago or more, if I could give one gift to the world, it would be for everyone to see themselves through everyone else's eyes.
Sure.
Because warped sense of self is just the cause of so many problems. Low self-esteem, I think, is very common. Unduly high self-esteem is also another
Right.
problem. We call that narcissism
Right.
or other things of, I think in some cases psychotic disorders are like where you have a lot of delusions of reference. It's just like your sense of self is like super inflated, where you think
Right.
that these people on this park bench are out to get you, and
Right. Why do they care?
and it's just
Right.
the inability to reality test
Right.
because you can't see yourself clearly. And but what she reflected to me was that I see people, and I think that a lot of what I've been moving towards with my photography is to. I just worked with a model for the first time last week, 2 weeks ago, and she's a trained model. She's a really talented woman, but I was like, man, this is what I'm born to do, because what I produced was exactly what was in my head. And I do have this benefit. I've looked at enough images now, and it's I have a feeling. That's what I notice and that's when I know the moment is right. And but to help people be seen, I think especially for me, I'm gravitating towards helping women be seen as an embodiment of the divine feminine, and not in a sexualized way, just as just being, And there is that sense of like wanting to be able to see and to be seen, that we have like this desire, and it is hard. Like we need good mirrors. That's what I've been saying, is like, I don't know how to see myself clearly. Like I haven't figured that out. And I do guided meditations and can't see anything. I'll go in a room and I'm seeing everything, and then I look in a mirror and there's nothing in it. It's a very strange phenomenon. I'm sure there's a deep Jungian explanation for it. I just haven't discovered that yet. But my substitute for now is just to have a lot of great mirrors. And some people, I think developmentally, their life, they're surrounded by people that are like funhouse mirrors. What they're reflecting back to them is very warped, or society will do that as well.
Yes.
And so then you're just like, you have a very
it.
false sense of self, and you don't know. That's called toxic shame or whatever you want to say. And so, one of the things I've learned is that like my success in life, and success is not how I want to think of it, my happiness and my well-being has directly correlated with me finding a bunch of better mirrors, just choosing better people who can honestly reflect back to me and also have the capacity.
Yeah, you become the 5 people that you spend the most time
so
with.
true.
Is the modern
It really
way.
is so true.
But it is
Yeah.
true, and yeah, I love that funhouse mirror, because I think what's happening, and I joke around with patients every day and say, as a father and a son myself, I have compassion flowing in both directions.
Yeah.
But
yeah, that's true. That's true. Yeah.
it's really interesting, because I think that unwittingly, and again, one of my best teachers one of his favorite sayings was, there are 2 types of people. You ask if we did therapy and training, and I did 90 minutes a week in that context for 6 years. It's a long time.
As a patient, as
a trainee, was in
You were receiving the therapy, not giving it. Yeah, 90
That's right.
minutes a week for 6 years.
90 minutes a week for 6 years. It's a lot of therapy.
Yeah.
And it's also a lot of therapy in that context, where you're with other very sophisticated, psychologically minded people who are, they're interested in this. And you.
What a fascinating population to work with too.
Yeah.
Psychiatric residents.
Yeah, it was it was a very cool experience. I drive by there to this day, and on the way over to the office on Dorothy, and I still to this day have a little heart tug when I go by, because it was such a brilliantly a positive experience. But I think I'm sorry, I lost my train of thought from what we were talking about.
Yeah, we were talking about the mirrors and
mirrors. Yeah, and so I think that compassion flowing both directions as a father and a son. And I think what happens is that if you're not in therapy, or you haven't been, my teacher would say there's 2 types: people who are in therapy and people who should be. And if you haven't been through a therapy experience, and therapy doesn't necessarily mean you lie on the couch and receive 12 sessions of CBT or whatever. I think lots of things can be therapeutic, but you are involved in some therapeutic practice where you elevate your understanding of yourself and the world and your role in it. And you start to see things more clearly through your adult eyes, because we all learn about ourselves through our child eyes, which has inherent shortcomings, right?
Yeah. Yeah.
Okay.
Yeah.
Right. So if you aren't in that practice, then you're subject to the funhouse mirror. And then when you become a parent, you use your funhouse mirror. Again, not with malice, but you use it because it's the mirror that you have.
Right.
It's how you see things. And all of one of the truths of fatherhood is that all the things that are both like, oh, look at that, he does that just like me, and oh my God, he does it just like me, both happen,
Yeah.
And so depending on your own internal ability to navigate that, right, your response can be very different.
Right.
And if it's something that's off-putting to you about yourself, that's an especially volatile, moment in that child's development, right? And you see the thing that you dislike most in yourself in that child, and you respond to it with aggression or hostility or trying to control it or whatever. And of course, inevitably, that has the opposite of the intended outcome.
Of course. Yeah. Yeah. Of course. Shame is a very short-term
Right.
tool. I
Yes.
mean, in the short term, you can,
Yes.
it will modify behavior.
Yes.
But, there's a saying I've said, you can, if your dog keeps crapping on the rug, if you can terrorize him, you can get him to stop. But if you do it bad enough, eventually he won't crap anywhere. He just won't go.
Yes.
I mean, that's
right.
that's the end stage result of shaming something for having a body.
That's right.
You know what I mean? And
you create the freeze response.
right. You just learned helplessness. Yeah,
Yeah.
right. I don't know what to
That's
do.
right.
Yeah.
And that concept applies in clinical psychiatry a lot. Learned helplessness applies a lot.
How so?
Well, just a lot of people have, for various reasons, some of which may have to do with environmental factors like how parents are approaching things or teachers, coaches approaching things, but also because they just may have differences in their neural development that they're not able to solve the problems that they're expected to solve. And a subpopulation that's especially prone to that are people who are really bright and capable, but who have some niggly thing that's in the way.
Yeah.
And so they are told, and then eventually they start to think themselves, well, why can't I do this? And then they just come to this point of they're resigned to failure. They just will sit down and quit.
Yeah.
I see it all the time.
Yeah.
And it's really sad because, it's the greatest resource. One of my patients who was head of human resources for a big company for a long time. He's in his 80s now. He always says the greatest resource we have as a country is human resources.
Yeah,
And so there's
true.
nothing worse than
Human
wasting.
capital,
Yeah, human capital. Wasting someone who really has amazing potential.
Right.
And all because they were looking in a funhouse mirror.
Yeah. It's just like or like life is just a series of funhouse mirrors.
Yes.
And for me, it's hard to tell. Now I'm on guard for flattery. I don't encounter a lot of flattery, but I have a bias, which is kind of like a cognitive thumb on the scale against it. It's much easier we all have a negativity bias, but for me, it's much easier to accept criticism than it is sincere compliments. And then flattery, it's like, man, I don't want someone to puff on my ego because it's almost like someone's trying to turn me into something useful to them.
Right. Sure.
But that's why we started this kind of line of conversation when you're talking about difficult conversations. And I've gotten to the point where when people, one of the things that flatters me the most is when people can tell me something, can give me real feedback, like criticism, constructive criticism, but say, hey, you could have handled that better. I would have expected more of you, whatever, because I'm flattered that they would respect me enough to tell me the truth and know that I'm not going to be a jerk about it.
No, it implies trust.
And they care, they care enough because I
right.
encounter people who I could give feedback to. You know what I mean? We all do.
Right.
But it's just this person's not going to take the feedback. Most likely there's some kinds of personalities where they're just they're going to treat it as a personal attack.
Amy would say the development of their soul is not ready.
You know what it is? That's it.
Right.
I guess that's for people who believe in reincarnation. That's probably some reassurance. But it is a cool thing to be able to have that capacity, but it's taken years of work and calming my nervous system to be able to say, and I think just, there's something, maybe it's just a personality thing, but I'm very interested in personal growth. Now, maybe that I'm wondering now, does that come from a fundamental assumption of inadequacy? Maybe. I mean, that if I'm just always wanting to grow, wanting to learn. I mean, I'm doing photography now. I did this one thing that's really cool, and I'm like, all right, now I need to learn how to use a speed light. I've never used that. What can I do with that? And I want to, a lot of filmmakers are like that. Francis Ford Coppola is just I don't want to make another Godfather. I did that once. I learned how to do that and didn't want to make a second one.
Sure.
Really didn't want to make a third one.
Yeah.
But they paid him, a truckload of money, and he was bankrupt, so he did it. Because he wanted to learn how to do something. It didn't work out, and I get that, but that's just something I'm very invested in. So I do take that, but it's I've been in situations where the mirrors that were reflecting back to me were not reflecting in good faith, and that's a challenge. So, and we now have a society where you can have a thing in your pocket that will tell you whatever you want to hear. And it's hard, I guess, how have you seen that change? As a physician, but also as a therapist, with the age of the internet, WebMD, chat rooms, social media. I mean, What's the change been like that you've seen?
Yeah, so I'm glad you asked that question because it's one of my favorite topics, and it's become more and more germane over the years,
Yeah,
right? I mean, it's
yeah.
just been this interesting
Strap
progression.
in, yeah.
And I do think, like a lot of times, again, this sort of the final stop on the journey. A lot of times, people have got a lot of that out of their system by the time they find us, so we'll probably not get it quite as much.
Okay.
But the way I try to explain this to people is, there's intellect, right? The native ability to learn, right? Some people just have better intellectual capability, and that's neither good nor bad, right or wrong. It just is, okay? Then there's knowledge, which you accrue through experience or study of one type or another. You can have a database in your brain. And then there's wisdom. And clinical wisdom is a peculiar thing because you can't get it in the short term. It's impossible. Like, no one can have it. There is no such thing, in my opinion, that there can be brilliant young surgeons because they can go in and they're doing some procedure that is a mechanical thing, and they're especially adept at that. And they could be brilliant in that sense, but maybe their colleagues would argue, but they're not brilliant in the post-op, or they didn't really always select the right patient for it. Or whatever. But they could be brilliant in that sense. They have this, again, this fluency with a procedure or some technical thing. But there are no such things as brilliant young psychiatrists. They just don't exist. Because so much of it is walking the path over a long period of time, appreciating the developmental context, watching how things unfold. No one can tell you that. And even if they could, they'd have to tell you 7 billion different versions of it, right? So each time people say to me, "Don't you get tired of talking to depressed people?" And I'm like, "No, I don't."
Yeah.
And the reason I don't is because I've never encountered two people with depression who were exactly the same. Everyone's story is different. The famous story about the tennis star Billie Jean King, she said, "I've never seen the ball cross the net twice in the same way." So she had this keen observational ability of the ball. She was attuned with the ball.
Yeah.
So she recognized that there were forehand cross courts and down the line, or volleys, or whatever you might be, but no two were exactly the same.
Yeah, yeah, that's interesting. And there's a what caught my attention was the attentional component of what you said.
Yes.
She sees the ball. Like
Yes.
she can follow the ball, and she
Yes.
remembers. That's kind of how it's gotten with me with photography. And I'll tell
Yeah.
people, like, well, or movies where I'm like,
Yeah.
no, but in that shot in the beginning of the second act when you did the thing and it was using a zoom on that, and it was the people are like, what are you talking about? Like, what shot? And but when you train the brain, you can do that. And I bet that there probably are some things where you have some cognitive shortcuts that you can employ, where it's like
Sure.
you said, like, okay,
Sure.
well, you've got this thing, you're 30 years old, you probably didn't have a heart attack. So this might be, I just know from
Right.
experience that,
Right.
what are some of those things that are like the no-brainers kind of, if there were such a thing in psychiatry that where it's, if it's when it's present, it's a pretty reliable indicator of
Yeah.
like a bad mood.
Well, that sure. I mean, I think like one of the things that's lost, and it's a shortcoming of certain ways that clinical psychiatric medicine is delivered and psychological medicine is delivered, is that if you're not in the room with the person, and again, I do telehealth. I'm a proponent of telehealth.
Yeah.
I think the fact of it is that people like me are in very short supply, and like lots of people need it. A lot of people who need it can't get in the car and drive to Nashville
Right.
4 hours one way or whatever.
Right.
It's like, or they can't do it with any regularity. So it is what it is. It's like everything, right? It's a mixture of positives and negatives. Things that make it good and things that make it maybe not so good. But one of the things that's missing is the observation of the person in the room and like their psychomotor activity. Like you said, what's an indicator of depression? Because true melancholia is such a physical experience. People who have had it will tell you it's a whole body experience. It's not just feeling sad or having a low mood. And one of the things is the psychomotor retardation or agitation in atypical depression, the rhythm and tone of voice. I always ask people something to start with, like, "Hey, what's been going on?" Or, what are you up to? And I do that with intent. Part of it is, I think, just like developing rapport is super important, and like getting to know people is important. Like what's up in their life, what's going on with their family, their friends, their interests, or whatever is important. But another part of that is just where does the mind go spontaneously? And again, sticking with the example of depression, people's minds will go to the negative. Like, well,
immediately.
Thought I had this opportunity, but this happened, and I guess I just am never going to have an opportunity. It's like, well, if that happened, that's disappointing, but like maybe you could work around that, but that's
Yeah.
not occurring to them.
Yeah.
But back to the whole advent of the internet, chat GPT,
Yeah.
intellect, knowledge, and wisdom. I try to tell people will bring me stuff from chat GPT or, other AI models. They'll bring me things that they've searched on the internet. And I'll say, okay, like this isn't necessarily wrong. It's just not right about you.
Yeah. Yeah.
Like, and that's what we're interested in.
Right.
One of the great paradoxes of clinical medicine is, if you think about the bell curve, right? The famous,
Yep.
all right. And so in the bell curve model says to practice safely and effectively, you really need to know about plus or minus 2 standard deviations from the mean, what constitutes the developmental norm, and distribution of characteristics. All biological characteristics seem to follow that if you collect a large enough sample that exists on the bell curve. But the clinical conundrum, and again, back to I've got some 6 or 8 or 12 week or even a 1 year study, which is a short time in the development of a human being. And it said that this particular intervention yielded this particular result. It's like the study tells you about a trend in a population, right? Which is great. It's helpful. You got to have that. And in fact, I would, again, to be fair, you can't practice safely without that. You need that knowledge base.
Right.
However, then we have the paradox of we're sitting with a group of 1 and we don't know where they are on that bell curve.
Right.
And so your job is to discover where this person is.
Right.
And guess what? Again, they're not always where you think they're going to be.
Yeah. Right.
And they don't always tell you right away either.
Yeah.
To
They may
report.
not know what to tell you. That's another thing you've thought of elsewhere. It's like, why
100%.
15 minutes is not enough time? Because there may be something super relevant, and you're like, because we have blind spots. We all have blind spots. That's one of the ways that the mind works to protect us is
Spot on.
Yeah.
You're absolutely spot on. And one of the things that good doctors in my world, this type of medicine do is they teach people how and what to tell them. Like by asking questions.
Interesting.
Does that make sense?
It's almost like a leading question,
Yeah.
but one that's not. It's not necessarily leading to a result, but it does presuppose maybe 2 options.
No, Andrew, people ask me, or people will say to me all the time, no one has ever asked me this. And they'll have been to a half dozen different.
Can you give me an example of a question that people will say without kind of?
Some of them are basic things. I mean, like just very basic things that I would consider like just, people that have had chronic treatment refractory, let's say, depression or anxiety. And no one's ever asked them about the possibility of hypomania or mania, which would, change the course of their treatment. No, head injury. People say, why are you asking me about head injury? I'm like,
Yeah.
and again, like.
It's almost like the brain isn't relevant to psychiatry in a lot of cases.
Well,
Yeah.
the historical criticism, the only specialty that doesn't examine the organ it treats.
Right. Yeah.
And that's changing. Imaging technologies come along, quantitative EEGs, functional MRI, PET, SPECT. Dan Amon's
DTI,
made a whole career out of SPECT.
Yeah.
I mean, it's like, there are ways to kind of look at it and to explore what's under the hood now that didn't exist. But I'm when I say people say, oh gosh, no one's ever asked me that, I'm talking about things that I would think of as basic things, like not asking me, for example, about if you've traveled. Like ask people that, have you traveled? Because people get exposed to things.
Right.
Both
Right. Yeah.
traveling. And we've got a patient right now who had an abrupt onset of some particular symptoms that could be construed as pandus. And this person has had exposure to a parasite. And sure enough, although it's traditionally associated with strep, there are reported cases of parasitic infections producing antibody that attacks the basal ganglia and produces a abrupt onset of
Pandus. It's what is Pandus again? It's a neurological.
pediatric autoimmune neurological disorders associated with strep. It's quite it's an acronym.
Pandus, right,
Yes,
okay.
Pandus, of
Pandus,
course.
okay,
Of course, Pandus.
Yeah, right.
They're the jolly bear from China.
Got it. Yes, I remember.
Yes.
I remember the one that everybody's really fascinated with their sex
Exactly.
life. Yeah.
Yes.
Yeah. So, what are the role of things like in your practice, diet, exercise, sleep, lifestyle? I mean, how much of your time do you spend on those factors relative to everything else?
Okay, so I call it getting the biological trains running on time. All right, and this is another thing, like the whole effect size and predictability on an individual basis. This is another one of those areas. So let's say that you have a novel antidepressant, and let's say that it produces you know, has an effect size of 0.4, which on the standardized inventories we're applying, it's good. It's really
it's pretty good. Yeah.
It's great.
Yeah.
So 40% reduction.
Yeah.
That's awesome.
Yeah.
What about the other 60%?
Right.
This is like in the opiate crisis world, like, opiates, like an opiate drug will, on average, reduce pain by about 30%. Where's the other 70%?
Right.
So we've known for forever. I mean, again, this isn't anything new. We've known forever that physical exercise enhances brain function on all levels, but especially cognition and attention, executive function. We've known that diet, like, I mean, here in the United States, I mean, my joke that I say that I tell kids things like McDonald's. I tried to think of the least appetizing name I could come up with, and I came
McDonald's,
I came up with non-nutritive gruel. I said,
that's a great way of putting it. Yeah,
but my nickname for the American diet is, if you think about it, the standard American diet. What's that an acronym for? SAD.
Yeah,
right? It's
that's
the SAD.
so true. It's the SAD diet.
It's the SAD diet.
It really is. yeah. That's just So seasonal affective disorder too is also SAD, but like it's like you don't get enough sunshine, you have SAD. Yeah, like, I mean, basically that's it. Like, you're not getting enough vitamin D from your skin, and like, you're sad.
And it's like, all the things that your mom or grandmother told you growing up turn out to be true. It's like you are what you eat. That's literally true.
Yeah,
I mean, hard to imagine
tissue's got to come from somewhere.
It's coming from somewhere.
Yeah.
And it's being supported by something.
Yeah.
And so, like, we've known for forever, the Mediterranean diet. There was a tongue-in-cheek article in Medscape a few years ago saying, should the Mediterranean diet be approved by the FDA for the treatment of depression? And basically the premise was, for a drug to get approved, it has to have 2 studies well done where it, exceeds or eclipses placebo and shows a favorable safety profile. And at that point, there were 3 studies showing the Mediterranean diet accomplished those things. And it's also cardiovascularly, it's probably the best diet. What kills Americans, cardiovascular disease at this point, right? Yeah, so.
Or stroke. Yeah, AVN. Yeah.
Exactly. Yeah. So the Mediterranean diet, again, which is easily accessible for most people, fresh fruit, fresh veggie, nuts, legumes, right? Olive oil, fish, cold water fish, right? So if you eat that, there have been a number of these, but there was a recent study that said for mild to moderate depression, exercise is as good as Prozac. This is a repetition of an old study. That's not anything new.
That was a Duke study. It was the original one, right?
Yeah.
And then somehow nobody wanted to find out more. Yeah, right.
It's
fun. Somehow there's not much of an incentive to find out that like something you can do for free works as good or better.
Absolutely.
Yeah.
Absolutely. And that is good for you, period. And there really isn't, like, what's the downside? I mean, I guess maybe you get a repetitive motion injury or something. You could argue if you,
that's true.
Long enough, you run. But when you think about the risk benefit analysis of antidepressants, for example, versus exercising, and I think most patients, when I say exercise, they think I have in mind they're going to train for the Music City Marathon or something. Right. I'm talking about taking a brisk walk.
Yeah. Yeah, well, it's for some people that's enough stimulus to be exercise.
Yes.
If you're sedentary, going up the stairs instead of
absolutely.
an elevator, just getting slightly out of breath on purpose several times a week.
Yes.
Like, that's really what you, I mean, Matthew McConaughey's got a witticism, which he's good for, is like, just try to break a sweat every day.
Yeah.
I mean, like, it's just like, you don't have to remember this many beats a minute of whatever and like 30 minutes of zone 2 and whatever. It's just like, just break a sweat every day. No, and not from going to the fridge. Like, just do it, like, on purpose.
Not from going to the fridge.
Right. Yeah.
That's from carrying the ice cream container.
Like, it's like I've got this tub of ice cream that I'm bringing back, and it's like a load.
Did you know? So the Mediterranean diet is famously anti-inflammatory, right? And so, one of the things we know is that inflammation in the deep limbic system is associated with depression and anxiety and bipolar syndrome. I mean, all these different things. Yeah. And so anything that will calm inflammation, omega-3 supplementation. But you mentioned, so we kind of hit diet pretty hard. Exercise. I mean, it's a no-brainer, no pun intended. There's pretty good evidence that if you vigorously exercise, it releases in the frontal cortical areas about the same amount of dopamine from taking 5 milligrams of methylphenidate.
I believe that.
Oh.
Yeah, it's very, I've found that what I was fascinated with at one point, I was, I've talked to you about doing PhD,
Right.
and I was interested in neuroscience for a while, and I'm glad I haven't gone down that road because I realize I'm more interested in people than data. I don't want to be in a lab looking at data the rest of my life, but the neuroscience of exercise. Why does it make me feel so good? Like that's really just and there's a kind of a profound thing because exercise or physical exhaustion, physical activity is kind of a component in a lot of spiritual practices.
Absolutely.
Runner's
I
high.
was thinking the same thing.
Runner's
as you were
high,
saying that.
flow
Yeah.
states, like there are these
Yes.
non-ordinary states of consciousness.
Yes.
Courtney Dauwalter is a one of the best ultra runners in the world. I think I don't know if she's still in the sport, but she won the Moab 240, I think like 3 years in a row. And she's this, little woman. She's just a beast. And she talks about going into the pain cave.
Yes.
And she'll hallucinate famously, and these critters will come visit her. She'll get 2 minutes of sleep in a 240-mile race in the desert. But she goes in the pain cave, and it's like a womb or something. And there's a dissociative element. Probably it's almost like people describe
course,
ketamine being in a K-hole. And,
Yeah.
But there's this non-ordinary flow to it with the repetitive movement, and I was always fascinated by that. And for me, there are different kinds of exercise. I think the thing that's I met with psychophysiologist Ryan Olson, I was at UNT. He's part of this kind of movement now of people trying to figure out a way to give prescribing guidelines to physicians for exercise, because it's clear that there are different interventions that are good for different things. Strength training is different from high intensity cardio versus low intensity cardio. And for me, low intensity, what before here, I came, it's like, I need to not be sleepy in the afternoon. If I get on a bike, an exercise bike, and ride for 50, 60 minutes at a low heart rate, under 130 beats a minute, it's so stimulating. I've got to be careful about how late in the day I do it. And whereas if I go run or I do something high intensity, I'll fall right asleep. Like it's like a sedative. And I can use them that way.
It modulates different networks and different neurotransmitters.
But you said 5 milligrams of methylphenidate. I'm like, yeah, that checks out.
That's about right.
That's about right. But there's no downsides to it, really.
There's no downside.
Other than you got to eat some more food, which some people would see that as a benefit. Like
hopefully Mediterranean.
Hopefully Mediterranean, yeah.
But no, there was something recently, because I have an eye on on any given day, I might have a 7-year-old, a 25-year-old, a 40-year-old, and an 80-year-old. Mm-hmm. And so I'm sort of like, so what's going on these the extremes of the lifespan? But, one of the things that's, a tragedy, and we're setting ourselves up for all manner of problems as a nation, is the obesity epidemic in kids. I see so many kids in my practice who are obese. I'm not talking about, growing up we all had
little baby fat or whatever. Yeah.
I was a chunky kid in middle school, and then I sort of grew, as my grandmother used to tell me, you'll grow into your weight. Don't worry, that kind of happened for me. But I see people who are morbidly obese as kids, right? And so there was this article, again, talking about how HIIT training, high intensity training, was preferentially effective for these kids and helping them get their weight down. And it's like,
of course,
you need to, and it's very like scientifically, presented like, oh, you should get your heart rate up and you should do it X many times in this interval. And then you should do it this many times a week. And it's better if you do it for a longer period of time than, meaning like over a longer period, like of weeks and months, than if you just did it.
You should stick to it.
Yes.
Basically, yeah.
So, and again, one of my aspirations in life is not to become an old man sitting on the front porch complaining about the government. This is one of my central life goals.
Yeah. Okay. Good.
But unfortunately,
good
luck. Because I was looking at that and I'm thinking, so recess. What do you do at recess? You go out. Somebody throws the ball, you take off running after. I'm going to play quarterback, okay, well, I'll be the tight end, whatever. You're running around and you're doing these bursts of activity and you do it every day. And it was built into your life, right? That was just something that you did. Even at 39, you probably did that. Yeah. My son and I talk about, my oldest son is 33, we talk about this. He just missed some of this craziness. Like, let's don't have recess in school.
There's no recess anymore?
There's no, or very little.
Really?
Yeah, recess. Well, because Andrew, after all, the most important thing is the number you get on that test.
That makes sense. That makes perfect sense. Yeah. Right. And of course, the best thing you can do is give them recess right before they do the test, because the neuroplasticity will be higher.
Yes. Yeah. Well, right. And I'm so glad you said that. The vigorous exercise enhances cognitive function by virtue of release of BDNF, brain-derived neurotrophic factor, known in neuroscience circles as miracle growth for the brain. So you literally fertilize the neural soil with exercise.
Yeah.
And yet we just decide like we should take that away so we can have 20 more minutes to study for I don't know whatever. So,
Whatever kind of math they're teaching, it ain't sinking in. Like it's 20 more minutes isn't going to matter, But I guess that, you could probably pay teachers for a few extra days because there's probably a number of hours per year the students have to be in school. So like that means that you can chop off days of pay at the end, if that makes sense. So it's probably a cost saving measure too.
well, I'll throw a shout out here to my good friend David Steiner, who is heads up a think tank at Hopkins on education. And so David, he travels the country trying to understand what's going wrong and how to remedy it. He wrote a lovely book about this if anyone's interested. But anyway, the fact is that for the first time, measured IQ and performance and all these different cognitive parameters are going down in the population. They've historically gone up, up, up.
Right.
And I think it's the most recent generation that they are
Down
now
a lot, right?
distinctly
Probably right
down.
on life expectancy.
Yeah, and so they're not learning. And like again, is it by complete chance that we took things like exercise out of the school? Is that maybe that had something? I'm not saying it caused it. I mean, I know that it's multifactorial, obviously, but it didn't help.
Yeah, that's interesting. I remember that because there's this thing called the Flynn effect, where IQ goes up, or you actually doesn't go up. You have to keep resetting the norm
Right.
by about 3 points a decade, which is fascinating. And it shows that like there's a lot of theories about why that is. I think a lot of it is that there's clearly some environmental factors that will definitely pull your IQ down. We don't put lead in our paint anymore or in our gasoline. Like that probably has a lot to do with it. People don't make a habit of handling mercury or I mean, like there's things that we do. We wear helmets during football now.
Yes.
Like,
Learn better.
Right. Yeah.
Yes.
I wonder if those numbers like the IQ and those are going down. Is that just in the United States or is it just in the industrialized world? Are we seeing it outside of the industrialized
The
world?
data I've seen is in the U.S. It may be true in a broader sense.
Europe
I
or-
couldn't speak to
who
that,
knows?
but I know in the U.S. it's true.
It's interesting. Yeah. And do you think that what else besides lack of exercise or sedentary lifestyle, gaming, like what do you think could be contributing to that?
Oh, I think that the screen addiction is a real thing, and I think that it's being introduced at younger and younger ages, and it's definitely impairing one's attention. I call and again, my son's a professional gamer, so I have to be careful what I say, but I think that certain types of gaming. My son is engaged in a type of gaming that's problem-solving gaming. He calls it poker meets chess, which is probably right. But a lot of the gaming that goes on, I call it the anti-neurofeedback because it trains your brain to have short attention,
Right.
and to expect a reward immediately.
One thing I've noticed, and I don't game, but I have in the past. That's very insane. There are these things called loot boxes that are, and I'm not a gamer. There's a whole psychiatrist that's dedicated to gaming, healthy gamer.
Yes.
I've told you
The
about
healthy
it. There's
gamer,
millions
yes.
of people.
Yes.
It's about 5 million followers.
Which says something, doesn't
The
it?
American
Yeah.
Psychiatric Association just published something saying that they've looked at that about him and about his coaching program because they're saying people are getting more out of his guidance than their own at the American Psychiatric Association.
shocking, yeah.
That's interesting. Now it also is. But there's this thing like these loot boxes. I guess in a game where it's just this big world. It's a sandbox game where you can just play, do whatever you want. There's little side quests you can do, whatever. But you're there forever, and it's a game that never ends. Like you never have to beat the game. So it's a good game to make. There's a loot box and you find it, you'll get like equipment or money or gear or whatever, but there's always a little cha-ching, and some stars that'll go up and these things that will prime, a dopaminergic response of like a little reward of like, oh, there's a little bell that goes off every time I get a loot box.
And
you
don't
wanna
think
keep
that's
getting a loot box.
don't think that's bad.
Of course it is.
So I mean, I was at a conference one time, and I'm a friendly type, and my wife is a psychologist, as I said earlier, and there was a nice lady seated beside me, and we just kind of chatted a little bit as the conference was starting. So at the break, we're getting a coffee and a croissant or whatever, and I said, "Oh, I see you're a psychologist. What do you do? What kind of are you clinician, researcher?" She said, "Oh, I work for the gaming industry," and my first response was Vegas. I said, "Oh, so you work for the casinos, or you the riverboat, gaming?"
Yeah.
She looks at me like I'm a total idiot, and she goes, "No, gaming, gaming."
Much bigger industry.
And I said, I'm still having a moment of being dense, and I said, "What do you mean?" She goes, like EA Sports.
Yeah.
That kind of thing. I was like, oh, gaming. And then again, the naivete persisted. And I said, well, what do you do for them? And she looks at me and she goes, I design reinforcement protocols. This is a sophisticated way of saying I make it addictive.
Make it addictive. Yeah. Well,
And-
and algorithms kind of do that they evolve to be addictive, and we're like, oh, we don't know why. It's just what gets people to use it more.
Yeah.
But yeah,
Yeah.
it's almost like, a
Yes.
physician, a cardiologist that worked for this, the tobacco industry.
Yes.
Like that's just like, there's something like, not to throw any shade at the people that do that, but it is scary that, the number one job in Silicon Valley are cognitive scientists.
Oh.
Like that's who's getting hired.
Of course.
Or computer scientists, but even them, the AI can do the computer science in a lot of cases. They need human computer interfacing experts, and that's scary. So it's like we have, as a society, a lot of things working against us. We're getting close to time to wrap up, but I want to ask you about one more thing since we're on this subject.
Yeah.
I think Australia has set a minimum age for social media.
Oh, right.
At 16.
Right.
And I just saw this was on Real Time with Bill Maher this last week. Someone was talking about it, that there's a site, the example was used, Steven Pinker, who's a great cognitive scientist at Harvard. He has this wonderful book out now called What Happens When We All Know That We All Know, something like that. It's common knowledge. Like when it's the Abilene paradox, when no one really wants to go to Abilene, but no one wants to say it. And then someone admits it. Everybody's like, well, who wanted to go in the first place? That now that one country has agreed to ban it, a bunch of other countries are setting this, are following suit.
Right.
And there's an interesting thing, and I'm not a parent, obviously. Maybe that's not obvious. I'm not a parent. But I have lots of age peers now. My brother and sister both have young children, and my sister's an educator. The challenge of having a child and who's going to say, all my friends have this, and you have as a parent, like there's that cohort model of development.
Right.
You don't want to deny them that, but it's also not good for them to be on their phone at, on the social media at 11 or 12. And it's almost like mutually assured destruction. Like it's like the nuclear arms race, where at some point we had to get together with the Soviets and start saying, let's just agree to, like, we'll draw down if you draw down.
Right.
And that's kind of what it has to be at a societal level, that we have to ban it for everybody, or else nobody's going to prevent their kids from doing it. What do you think about that, just as a child psychiatrist and as a parent, about banning social media at that age? And
Yeah, and to some degree, my oldest son, he'll tell you, if he were sitting here with us, he'd say, I dodged a bullet with all that. Because he's just old enough that it really wasn't.
On the phone.
Yeah,
that was the thing.
and he's just, for a variety of reasons, I think it wasn't his temperament to be into that sort of thing. But our younger boys, Amy and I, fought the good fight, maybe a certain degree of naivete without that experience necessarily with Mason. Fought the good fight on keeping those devices out of their hands until they were 13 or 14. They've had them now the last couple of years. We've really tried to have parameters around it in various ways. One of the parameters that I encourage parents to have is that at any point, if I say hand me your phone, you hand me your phone, and at that point, I'm sorry, I may be violating your privacy, but I'm going to look at your text messages. I'm going to look at where you've been on the internet. And there are programs that do this. And I prefer the personal touch, which is, instead of like, Covenant Eyes is going to tell me you're looking at porn or whatever, then I'm going to see it. And then we're going to have a conversation.
Have a difficult converation about it.
Have a difficult conversation.
Right? Yeah, right. I bet.
Exactly.
Having you as a father, my God, I haven't even asked about that. Okay, go ahead.
Yeah, but and I think that, again, those kinds of safeguards, our boys, neither one of them, it's never really been a problem with them. Although I think that so from a personal level, I think we've navigated it reasonably well. That you alluded to the whole idea of the cohort effect, and that is definitely an issue. My boys were, from the time they were 10, they were like, everybody else has a phone. Why don't we have a phone? I need a phone, blah, blah. I'm like, you don't need a phone, right? I'll get you a flip phone. Well, what if there was an emergency and I can't call you? Well, I'll get you a flip phone. No, because then I've got, It's
We're like, look at this dork with the flip phone. But billionaires like them now.
That's right.
Yeah.
Well,
now
all the Silicon Valley dudes won't let their kids.
They won't let their kids on. Yeah, Facebook. The people that work there won't let them kids on them. Yeah.
Yeah. So I think I would encourage people to definitely put it off as long as you can, to appreciate that there probably are benefits to having it and being part of the group and messaging one another. And one of the things I figured out they do is they do these FaceTime calls that last all night. And they have all their friends on the FaceTime call, and they're all talking to each other.
Yeah.
Or they're, sometimes I come in and they're doing homework together, which is kind of cute and sweet, and and that's fine. But just also being really clear that when you're 13, 14, 15 years old, as a neuropsychiatrist who thinks a lot about neural development, that child doesn't have the frontal control to exercise good judgment around those things. And
Frontal lobe control, inhibition, and
that's right. They need their parents to help them with that. And of course, they're going to resist because that's their job as a teenager.
It's to be resistant. To be individuating, and
yes. But then they're going to love you for it later. So, now, the social media thing, there's a phenomenon in adolescence called the imaginary audience, right? So I imagine that I'm the focus of everyone's attention. A corollary of this is the 20, 40, 60 rule, right? When I was 20, I said to myself, I have to date the right girl, wear the right clothes, drive the right car. When I turned 40, I said, I'll date who I want, wear what I want, drive what I want. And when I was 60, I realized no one ever cared anyway. And so you're delivered from that imaginary audience through your adult development. But as a teenager, it's very real. And so one of my 20-something Vanderbilt kids said to me, my favorite comment ever on social media, she said, you don't meet the person, you meet the representative.
Right.
And it's hard as a kid to understand that this is curated. And I say to young patients, well, how many times have you seen like images on your feed, your Instagram feed, where people picking their nose?
Right.
Have you seen any videos of people stumbling and spilling coffee all over their brand new suit or dress? What about a video clip of the knockdown drag out they had with their family last night? You seen any of that?
Right.
Yet, do people pick their nose? Do they spill coffee? Do they get in fights?
Right.
They do, don't they? So what are you seeing? Like you're seeing, this is curated or selected. It's to put forth a particular impression about things that probably doesn't fully reflect reality. But if you buy into that, you think, look how fabulous their life. What's wrong with mine? And that's part of that imaginary audience. Mm-hmm. And then when you put an image out there, you imagine that people are, if they don't, thing I hear all the time, I posted and no one liked it. Well, I tell my boys, like, well, maybe they were doing their homework, or maybe their parents had good judgment.
Maybe they were doing their homework. They probably weren't, but it's a nice thought.
Getting some tennis balls.
Right, actually they're doing something in the real world.
That's right. Maybe they weren't looking at their phone going, when is he going to post?
Right.
And so, again, because there's that natural social anxiety at that age and that natural comparisons going on, it drives people to levels of anxiety that, I don't think it's happen chance that the incidence in the clinical level of anxiety has gone up ever since the introduction of the iPhone and social media. In that
anxiety.
Yes,
well, there's Jonathan Haidt's book, The Anxious Generation.
Yes.
This is written a lot about
That's
this,
right.
and it's kind of scary.
It's spot on too, by the way. I can tell you from a front row seat, he's right.
That you're just seeing a rise in anxiety disorders in adolescents.
Absolutely.
Is that tracking? Is that being followed by a rise in like prescriptions for?
Oh, of course.
It's got to be, right?
Of course.
Benzodiazepines or
right.
Yeah, or any other anxiety drug. Yeah.
Sure. Anxiety medicines and the SSRIs and these type of medicines. And again, it's not that those medicines don't ever have a role, but like if you fun fact. So depending on let's take ADD because it's an especially good example. ADHD is a powerfully biologically determined condition. It's the heritability coefficient, which is a measure of how much of the phenotype that you ultimately see is biologically driven. It's about 0.8.
Oh, okay.
Yeah. So 80% of the phenotype is driven by biological or genetic factors. It's highly heritable. No, people say, well, that means 20% is environmental, and it's true. So you can do environmental things, and that can help. Mm-hmm. It's not to say that environmental things never help, but it's the bulk of it. If you look at depression or anxiety, it's about 0.55.
Okay.
That means almost half of what you see is environmentally driven.
Right.
So environmental decisions that you make, like do you exercise, do you sleep, do you eat a healthy, balanced diet? Do you stay away from toxic things like alcohol and drugs? Do you stay away from toxic relationships? Like, do you curate friends in a way that they are going to affirm you and build you up and really love you and support you? Or do you have people that which mirror are you looking in, right? Because in adolescence, your friends are your primary mirrors. and they all have underdeveloped brains themselves, right? Right.
Right. They have terrible judgment. Right.
They have
It's like
terrible
them and meth addicts
right.
are just like the group.
Right.
You never want to ask for
ChatGPT.
advice. Right.
Yeah.
Yeah.
Let's go ahead and tell them what you really think.
Right. Because they're a meth addict, they thought it was a good idea to
Yeah.
ask ChatGPT about how much meth to take, and like
Yes.
there you go. Right.
Yeah. I can't count
And
through
there's some things, kids, adolescents will say things you're just like, what in the hell
Right.
were you thinking?
Well,
It's
no.
just so boneheaded, but it's what they're like. Yeah.
I lose count of the number of times I've said to adolescent patients that I've worked with, if you have to start it with, okay, I don't mean to offend you, but
Right. Yeah.
just keep that thought to yourself until you can think of a way to deliver it in a more kind, compassionate way.
But I mean, half of depression and anxiety roughly half comes from the choices we make.
Environmental factors.
I think there's probably no better way to wrap this episode
Yeah.
up. So thank you so much for joining us, and I'd love to have you back.
Absolutely. I'd love
We've
to
got
be
an
back.
episode break coming, and we've got another we're going to record soon, but that'll be out a little later.
I look forward to it.
All right. Thank you so much, Dr. Clark.
My pleasure.
All right. We breaking? All right. Great. We're good on time. Oh, good. Okay.
Yeah.
We'll have enough time for
Yeah.
maybe a little